Hello, I'm Manoj Karmakar. I'm your host, and I'm the convener of the ISSPS 2021, the International Symposium on Spine and Paravertebral Sonography. It gives me great pleasure to welcome you all to this 6th webinar of our series. Today, we truly have a festival of science lined up for you, and I'm confident with my colleagues that are going to join me in delivering this topic to you. I'm sure you will not be disappointed. Before I begin, I'd like to welcome those who are joining us for maybe the second, fifth time. If you are joining us for the first time, welcome. More importantly, if you are not registered, I would suggest you should register, because you will have access to these recordings of the entire series once the program is over in December. It will come to you live via YouTube on ISSPS TV. So we will send you these details via the email that you would register with. So remember to register. Okay, first of all, we are coming to you live from our beautiful city in Hong Kong. We have fortunately overcome some of the pandemic that has taken over the entire world. But I am also pleased to mention to you that the pandemic has taught us how to communicate with one another without really being in touch in person. We are from the Prince of Wales Hospital, the Chinese University. This is where we are coming to you live from. We are one of the two medical centers in Hong Kong and basically affiliated to the Chinese University of Hong Kong. This program is being organized by the Department of Anesthesia and Intensive Care, and also in celebration of the 40th anniversary of the Chinese University of Hong Kong, to our young university. Also, I'd like to take this opportunity to thank our sponsors and supporters, particularly Payung, Bygone, Pacific Medical, Waysonic, and Konica Minolta from Japan. They are all innovators. They have innovated many new equipments, whether they be block needles or they are catheters or ultrasound machine. I hope you will reach out to them if you need any one of their products in your country, and I'm sure they will be more than happy to provide you the necessary details. I'm pleased to inform you that today, as of today, we have more than 3,000 registrants, and many of you are logged in here this afternoon, evening, morning, wherever you are in this world, and I trust you are well and healthy. As I said, we have a festival of science lined up for you, and with the help of some of the colleagues of mine, we will hopefully deliver to you a truly fascinating program. I'd like to first take this opportunity to thank these faculty who have joined us from different parts of the world, and particularly for sparing the time to be here for this session. First is Dr. Georg Feigl, a good friend of mine. He comes from the University of Witten in Germany, the professor of clinical anatomy and the Institute of Anatomy and Clinical Morphology at the University of Witten. He's very well known in the field of anatomy, clinical anatomy in particular. He has published extensively in anatomical journals, including in anesthesiology, such as Regional Anesthesia and British Journal of Anesthesia. And those of you who follow this subject have read many of his recent publications in our specialty. He's also contributed and written several textbooks, and he's been invited to speak as a speaker at innumerable conferences around the world. He's joining us today for the second time. I'd like to take this opportunity to give you a warm welcome, George. And this is truly our effort to bring clinical anatomy and regional anesthesia together. I say so because never in my career have I learned more anatomy since the advent of ultrasonography in our specialty, and I'm sure you will relate to that. I think sometimes we are a little bit careless in what we say about the terminologies about in anatomy. Sometimes very casual mentions are made about different anatomical structures, but I think we have to now take it very seriously and really know better than a true anatomist who can be with us. And a warm welcome again, George. Next, we have another great individual. I can describe him as a good friend, a great researcher, someone who's always searching for the truth, has contributed in the field of anesthesia and particularly regional anesthesia for more than 3 decades. He has been a great inspiration to many. He has been a teacher for many, including yours truly, in terms of the inspiration that he has instilled in many of us who are in the field of regional anesthesia. He comes originally from Pretoria in South Africa, and for you, ladies and gentlemen, that's Professor Andre Boezaart. After completing his initial residency and training in the Stellenbosch University, where he also did his PhD, he emigrated to the United States, initially working at the University of Iowa, and after a number of years, he moved to Florida, at the University of Florida in Gainesville, where he was a professor of anesthesiology and orthopedic surgery for a number of years. A special mention has to be made about his contribution to the war in Angola, because it was during this time that Professor Boezaart was really providing regional anesthesia in the form of pain relief, acute pain relief to war wounded, so much so that today some of the techniques he used are used in many of the countries, military around the world, including the United States military. He's also innovated the stimulating catheter that we are also familiar with today. He's published extensively. I needless to say, he has contributed in many textbooks, which many of you own and are familiar with. He's a reviewer for several journals, and I have to thank him for being a reviewer to many of my articles. He's today a chief medical officer at the Lumina Pain Medicine Collaborative and the Alan P. Winnie Research Institute. He's also an emeritus professor of the University of Florida, Gainesville, United States. He's contributing academically from a laid-back still bay in Western Cape of South Africa. I wouldn't say he's retired, but he's still very active. And today he will be joining us, although his presentation will be coming to you as a recorded presentation. But Professor Boezaart will be with us, and he will be joining us for the Q&A session. So if you have any questions for him, then he is the right person for that. Next, we have Professor Miguel Angel Reina, another good friend of mine. He really is the person who has really highlighted the significance and importance of microanatomy of nerves, ultrastructures of the human spinal meninges, and he has researched in this area for over 2 decades. He's a professor of anesthesiology at the University CEO San Pablo School of Medicine in Madrid, Spain. He's also an adjunct professor of the Department of Anesthesiology, the College of Medicine, University of Florida in Gainesville. He's published extensively. His textbooks in microanatomy is truly a reference on the subject. If you don't own one and you are in this field, it is a must-have. He's been an invited speaker to innumerable conferences, including the issps. So he's joining us today for the second time, and he will be discussing microanatomical aspects of the brachial plexus and the sciatic nerve. Before we get the program going, a couple of housekeeping issues. And this is a webinar. You will have limited privileges, but you can always ask questions in the queue as a form of Q&A. So please pose your question through the chat function. Do remember to include your name and where you come from. And one of our moderators in the panelists will pick up your question and then ask the question on your behalf to the panelists during the Q&A. Now, since we have a fairly long program, we will have 3 lectures followed by a Q&A before the break. And then we'll have another 3 lectures before the Q&A, before the end of the show. So these are some of the textbooks that come out from our stables. So if you're interested, do get in touch with us. Also to remind you, next week will be another festival on brachial plexus, showing you the latest developments in imaging, scanning techniques of the brachial plexus. So if you are interested, and why not, you should be, then 30th October is the day you should remember where you should be joining us. Okay, without further ado, it gives me great pleasure to welcome Professor Georg Feigl to deliver his lecture on functional anatomy of the brachial plexus and common anatomical variations. Welcome, George.
That's the brachial, yeah. So thank you very much. And dear audience and also colleagues, I just want to give you a brief overview about the brachial plexus concerning the topography and also certain different structures which are very important for block techniques in the area of the brachial plexus itself. Just briefly, a short repetition for you all concerning the different parts of the brachial plexus, what you will try to block in the different anatomical areas. So as you can see, first of all, you get the ventral rami of the spinal nerves, then the trunks, which divides into cords, and then finally the nerves are formed, which are running to the distal parts of the upper limb. And this is a very important thing concerning also the terminology, because very often it's called root, which is not that correct from the anatomical point of view, because the roots are more centrally, so in the spinal canal, and not in the area of the interscalene gap.
Sorry, George, can you please use the slideshow? Slideshow.
Oh, sorry. Yes, of course. Do so. Hope it should work. Yep. Okay.
Thank you.
Does it work? Yeah, sorry. And for the next, you can see that you find it, first of all, have these ventral rami, which are regularly found in the interscalene gap. So where you block, you will perform the interscalene block, you get this ventral rami. Then they are dividing into the different trunks where you can perform the supraclavicular blocks, and continuing with the formation of the cords, which is already infraclavicularly. And then finally in the axillary fossa, in a very huge space, which is determined by the deep axillary fascia, as you will see a little bit later on, you have these axillary brachial plexus blocks to be performed over there. And in this axillary fossa, you can see the cords are already dividing into the different nerves, which are running distally and innervating different areas and muscle groups. So if we can make an image, for example, this is a topographical dissection, which is also with an abducted arm, where you can see the formations of the different areas. And the first line is the level of the clavicle, the second line of the lesser pectoral muscle, pectoralis minor. And then you can see over here, this is the formation of the trunks, where you get the ventral rami passing the interscalene gap, then forming the trunks, and then already forming under the clavicle the area of the cords, which are dividing later on in the axillary fossa into the nerve fibers. This is a systematical dissection, which means you can see all the different nerve fibers, but you can already see there are very, very huge connections and fine connections in between the different nerve structures, which is also very important that you get so many different variations concerning the brachial plexus itself. So you get these four regions, and I want to give a short overview of each of them to start with the interscalene gap. Before, again, with the clavicle still in place and also the pectoralis minor, you can see the different areas which has to be passed by the brachial plexus parts. So the interscalene gap, which is really a narrow gap and not very much space for any structure being in there, are also continuing with the supraclavicular region, which is also the so-called posterior triangle of the neck. Then you get now the interscalene gap. This is, as you can see again, this narrow gap in between, where is soft connective tissue inside, and in between, and you can see already different arteries and passing along. As you can see, for example, here the dorsoscapular artery, for example, which is originating from the subclavian artery, lateral to the interscalene gap. Regularly, it should originate from a trunk, which is medial to the anterior scalene muscle, which can be seen over here. And there are also some other arteries, like here. This is the superficial cervical artery, which is superficial to the so-called prevertebral fascia, which you will see a little bit later on. And also here dorsally, you can see separate nerves which are piercing the middle scalene muscle to reach the lateral part of the thorax, for example, which is the longus the long thoracic nerve, as an example. Anyway, this is just an image with certain structures missing, and this is a very important information for you, because the first of all, we have to talk about the structures which are also limiting and also bordering the entire space where you find the brachial plexus itself. So first of all, about the prevertebral fascia, to give you some important information, and also the so-called prevertebral space. Then a short contribution concerning is the fascia underneath. So just around, for example, the brachial plexus parts. And then a very important also discussion, which is still ongoing, where there's a local anesthetic which is injected underneath this prevertebral fascia is spreading to, is running to. And of course, one of the most important things for us that we can also publish about is, of course, the variations which are found over there, and which can be a little bit irritating for you performing ultrasound. So let's talk about the prevertebral fascia. I just want to give you an impression how also some images which can be found in textbooks for regional anesthesia can be wrong. And this is something what you always have to think about and question. Are the images, what you see, are really correct? For example, this image over here, wonderful, nice image, wonderful drawing, but with some small errors in it. First of all, you get too many contributions to the brachial plexus. You get 6 instead of 5. So you get one too many. The second thing is, for example, that you have the accessory phrenic nerve, which is passing dorsally to the anterior scalene muscle. This is impossible. The next thing is the rib. This is not the first rib. This is a second rib, because the first rib is more flat, and also really giving enough space for the brachial plexus, for the infrared trunk, and also for the subclavian artery and vein to pass cranial to it. And most important, you can see over here this fascial tube, which is passing underneath the clavicle and is continuing from maybe the epineurium. And this is wrong. This is absolutely wrong. This should be a fascia which is covering the scalene muscles. And this is something what you also always have to question, especially that you get a very, very unique and wrong anatomical overview. And also you cannot explain different spreads, for example. So what about this prevertebral fascia? You can see this prevertebral fascia in a dissection over here, which is a dense connective tissue layer, and also covering a second nerve, which is arriving from the cervical plexus, which is the phrenic nerve. And you get also contributions from the brachial plexus, as for example, C5 segment, which is giving some nerve fibers to the phrenic nerve also. And underneath this prevertebral fascia, you find the narrow space, which is filled now with the brachial plexus, all the connective tissues, and also different arteries and so on, which are in this space. So the space is already almost filled up. You have to consider this if you inject high volumes, as an example. Fortunately, with ultrasound, you decrease the volume, and this is a very important thing, that you also decrease the risk of not welcome spread. If you now elevate this fascia, you can see the space and the brachial plexus, which is covered by this epineural sheets, and they are always already spreading. And the phrenic nerve, which is running along the anterior scalene muscle to reach the thoracic cage. If we take now a cross section at level at about C6, C7, you can see over here, these are already the structures of the brachial plexus, so the ventral rami running laterally, and you see the epineural sheets just around, with not very much space for the nerve fibers underneath this epineural sheet. But what is more important is that you can see this is a space which is continuing medially into the spinal canal, which means that you get the prevertebral space as a continuation medially into the epidural space directly. If we take another cross section and then make an elevation, you can see over here, these are now the ventral rami of the brachial plexus, and just beside, just directly beside, this is the phrenic nerve, which is now marked with a yellow arrow. This close relationship is really the high risk that if you get a cranial spread, you really a risk, you have a high risk to reach or to block the phrenic nerve additionally. If we make now a so-called sagittal section, you can see now the anterior scalene muscle running distally, and over here, this is here, sorry, and the anterior scalene muscle with the interscalene gap. And you see, this is not very much space in between because it's the first rib and the subclavian artery. If we take a second image, you see the prevertebral fascia with the anterior scalene muscle being covered by it, and over here the brachial plexus parts with also the middle scalene muscle, and then muscularly bridges which are developed in between the middle and the anterior scalene muscle, and these can cause a confusion because regularly there should be nothing in between artery and the brachial plexus, but sometimes you get hypoechogene structures, which might be these muscle bridges. If we elevate now the prevertebral fascia, you can see the phrenic nerve, which is covered by this fascia or being inside of this fascia. So any spread, which is medially and anterior or cranially, might reach this nerve, of course. If we take now again a cross-section, you can see again this prevertebral fascia with this distinct dense connective tissue layer and the brachial plexus underneath. And you can see again the epineural sheaths, but no fascias which are surrounding these nerve fibers. So this is not an additional fascia or a fascia which is covering the anterior or middle scalene muscle, but you get this space with dense connective tissues formed maybe by the epineural sheath, but I hope we can hear it later on by the histological investigations. Another cross-section, which is now enlarged, you can see again the prevertebral fascia with the phrenic nerve. And let's take a look on this close relation in between the superior trunk, and this is the C7 segment, which will form the middle trunk. And again, also over here, the anterior and middle scalene muscle with the muscle bridges, which can divide these trunk parts from each other. So regarding now the spread, you have to take into consideration that any injection underneath the prevertebral fascia might be or might continue with a medial spread, and the medial spread can be now reach the epidural space in the spinal canal, but it also might pass behind the anterior scalene muscle medially into the so-called scalenovertebral triangle, or into the mediastinum to reach the aortic arch, as an example. So this is a very important thing that you can explain later on also some side effects like the hoarseness, which is caused by the block of the recurrent laryngeal nerve, as an example, or the Horner syndrome, which is caused by a block of the sympathetic trunk. And the sympathetic trunk parts are found in the scalenovertebral triangle. So what about now variations? Oh, well, they are quite common. As an example, the scalenus minimus muscle, described long time ago. And you can see over here as an example, one of these dissections where the brachial plexus is separated from the subclavian artery by a distinct muscle, which is reaching the pleural dome. And if you find such a muscle, again, with a lateral view with the pleural dome, you have an hypoechogene structure in between the artery and the brachial plexus dorsally. If you get a hyperechogene structure, well, the muscle is replaced by a ligament, as we'll see later on. And these ligaments are quite known. They are known since more than 170 years. They are called the tuchocandal sabular ligaments, which are fixing the pleural dome to the bony parts. And one of these is, for example, the costopleural vertebral ligament, which is, if is developed as a ligament, called costopleural vertebral ligament. If it's a muscle, it's the scalenus minimus, nothing else. So quite well known, and they are very frequent. As again, you can see these muscle fibers, muscle bridges, which are in between the middle and the anterior scalene muscle, quite common. And these frequent, you get a frequency of about 40% of these connections in between these muscles because they are developing from the same myotome. As you saw it just before, you have these muscle bridges in here. Okay, if you get the pulse in the in between, for example, the superior trunk and the C7 or the middle trunk, this might be an artery which is passing and running dorsally, which is the dorsal scapular artery. Quite a common one, and also quite frequent in about 30% to be found in this area. So let's go now continue with the posterior triangle of the neck. You get the supraclavicular blocks over there, as you can see, and now here this variation with the artery passing in between the superior and the middle trunk. This is the dorsal scapular artery. And you can see over here, this is the superficial cervical artery, which has a close relationship, which can be seen quite easily in ultrasound, of course, but this is separated by the prevertebral fascia, so it's not in the same space. As you can see it over here, this is the prevertebral fascia still being in its place. You see the brachial plexus passing underneath and the superficial cervical artery running laterally to reach the trapezius muscle. It's a little bit enlarged, and the question arises now, well, if we get now a shoulder block, for example, in this area, are we safe? Do we get everything? And the answer, unfortunately, is no, because the supraclavicular nerves are missing, because they are superficial to the brachial plexus and also superficial to the prevertebral fascia. So as you can see it over here again, with a lateral view now, with the prevertebral fascia and the middle scalene muscle and the brachial plexus, with the next image, you can see from a cranial view the prevertebral fascia, and the supraclavicular nerves would be superficial to it. So if you want to have a shoulder block, you still have to think and to take into consideration to take this trunk of the supraclavicular nerves to also block the innervation of the skin area in the shoulder region. And this is quite easy because if you go cranially with your probe, you find the trunk passing and piercing the prevertebral fascia just at level at, well, C5. And then you get really a very distinct block over there with a low volume of about 1 milliliter, not more. And you get a wonderful block of the entire trunk to get a safe block and of the shoulder region. Another variation, which is not that often, but quite unusual, is the ribs of the neck, which can entirely change your topography in the area of the supraclavicular region and also of the interscalene gap. And the longer this neck rib is, you can see the more this will change your entire visibility and also entire imaging of this area. Additionally, you find another muscular regions, especially in the lateral triangle of the neck or posterior triangle of the neck, which are formed by muscles coming from the deep and reaching superficial muscles like the sternocleidomastoid. And these are quite common and also quite frequent because, again, you get these muscle bridges by the development. This is, for example, a clavicular muscle or atlantoclavicular muscle, for example. Okay, let's go to the deltoid pectoral groove, which is also called the Mohrenheim grooves, where you can find underneath the continuation of the prevertebral fascia, which is the clavipectoral fascia, then the the cords of the brachial plexus just located lateral to the subclavian artery. And which is most important is that you have the cords formed and also positioned, that you find the lateral cord as the most ventrally and lateral one, then you have the posterior cord, which is a little bit dorsolateral, and dorsal to the artery is always the medial cord. This is caused by, well, let's say the direction the medial cord is formed, and this is a continuation of the inferior trunk by the ventral part of ventral division of the inferior trunk. So it's not much space for the medial trunk to get more medially. So at the area or at level of the infraclavicular region, you have the medial cord dorsally to it. Again, I just want to give you a very important publication, which is of Abraham Kerr. And Abraham Kerr investigated about 220 brachial plexus, and he found 140 variations. So if you see more than 3 nervous structures in this area, you get a variation. Because you are always thinking about, there have to be 3. No, there can be more, and there can be less. So you have just to visualize the nerve structure and to go on it and to reach it with your needle. The problem is that if you go underneath, you have the pectoral muscle, you have the deltoid muscle, you have the cephalic vein, then this groove, this distinct groove, where you can continue, and you have this lesser pectoral muscle, or the pectoralis minor, this clavipectoral fascia, and then you go underneath this fascia, and you have the brachial plexus dorsal to the artery, as you can see it over here. It's the subclavian muscle in the sagittal section with the clavicle and the vein, and then a space which is continuing dorsally. And this is a very important information, that if the needle is placed not in the proper position, you get a spread dorsally and will not reach, for example, the inferior trunk or the medial cord as an example. We can see also this continuation of the epineural sheaths forming already so-called fascial tunnels in this area, and again the dorsally located space. So if the needle is placed too deep, you get the spread dorsally, and it will not reach any area, for example, such the medial cord. So if you inject or perform, for example, the so-called whip, which is the vertical infraclavicular block, this might be the risk, and therefore it's quite useful. For example, like the costoclavicular block, which is while reaching really the entire area quite easily. Okay, let's go finally to the axillary fossa. In this axillary fossa, you find, of course, the so-called nerve structures also being accompanied by the artery and also the vein. The coracobrachialis muscle, which is a very important landmark in your ultrasound image, and of course the greater muscles like the pectoralis major and also the latissimus dorsi muscle. In this axillary fossa, you get now the final division of the cords into the nerves. And you know that, for example, from the lateral cord, you get the musculocutaneous nerve. And this is already the bad boy in this area. Additionally, you get the ulnar nerve from the medial cord, and from the posterior cord, the radial and the axillary nerve, where the axillary nerve might not be reached in all your block techniques. More important is that you find over there a fascia which is covering the entire brachial plexus. This is the so-called deep axillary fascia. And if you insert the needle, you get this deep axillary space. And the deep axillary space is a continuation of the space underneath the clavipectoral fascia, and therefore of the prevertebral fascia. So in common, you get the same space underneath the deep axillary fascia, which is continuing to the interscalene gap and continues also into the epidural space. But you get the deep axillary fascia, which is also dividing the deep axillary space with the brachial plexus underneath and the so-called subfascial axillary space. Why do I say this? Oh, well, there is a nerve which is running distally, which has to be considered to be blocked for especially medial, medial surgical procedures at the elbow joint. And this is the so-called intercostal brachial nerve. Well, let's talk about the deep axillary space. This is the deep axillary space, and it was said to be, okay, if we go underneath this fascia, we get an entire spread around all these nerves. Unfortunately, this is not that true because, as I already talked about, the epineural sheaths, which are dividing, and they can form really so-called connections in between each sheath, each epineural sheath, and therefore forming some tissue layers which are like walls in between the different nerves. So if you put the needle just, let's say, on the median nerve, it might not spread dorsally because there are distinct walls in between. And this is the so-called subfascial axillary space with the lymph nodes inside, and then the so-called intercostal brachial nerve, which is passing. Okay, over here, so-called transverse section with the axillary artery, and you can see the nerve fibers, and this is the deep axillary fascia over here. Again, the deep axillary fascia with the nerve fibers, and you can see even distinct over here some dense connective tissues which are forming real tunnels in between, and then which is not visible, but hopefully might be visible someday by histological sections, these interconnections in between. So what are the bad boys now? I'm just almost finished. You get the musculocutaneous nerve as an example with which might have a so-called high origin, and if you perform over here your brachial plexus block, it might not reach the nerve. So it's quite easy to get him in the area or directly in the in the coracobrachial muscle. But anyway, you might not reach the axillary nerve, which is more proximal. So you can see this is really a problem, but it can be performed, for example, if you move the probe more proximal and then get it in the quadrangular space, as an example. And the intercostal brachial nerve, you can see over here, this is a nerve which has to be blocked separately. And then if you go underneath this, deep axillary fascia, you will reach the intercostal brachial separately in the subaxillary space, subfascial axillary space. Okay, other variations is this high origin of the musculocutaneous, which is not that problem because the visibility of the nerve in the coracobrachial muscle is quite easy. But anyway, also some others are the longus arches, which are so-called muscular bridges, which are coming from the greater pectoral muscle or from the latissimus dorsi to each other. So from the latissimus dorsi to the greater pectoral muscle, you find these muscular bridges, and they are also hypoechogene structures which are crossing directly. And just have one image over here, like this, from the greater pectoral to the latissimus dorsi, or other way around. You have this very irritating structures which might cross in this area where you perform the axillary brachial plexus block. Okay, so from my point of view, I hope I gave you a short overview about different variations and important structures which has to be considered. And thank you very much for your attention.
Thank you, George. That was a wonderful presentation. Ladies and gentlemen, how good was that? I think this really highlights the importance of anatomy. The core understanding of the basics of anatomy are basically the building blocks of regional anesthesia, whether you are successful or unsuccessful. Thank you, George. Don't go away because you'll have to answer some interesting questions. Okay, it gives me great pleasure, and as I have introduced to you before, the next speaker is Professor Andre Boezaart. As I also mentioned, we are going to use a recorded presentation while he is still relaxed in his chair in Still Bay in Cape Town. Welcome, Andre. I can see you now, and we're going to start your presentation.
I'm Andre Boezaart, and the topic I was asked to present today is the microanatomy of the brachial plexus and its implications for regional anesthesia. I thank Professor Karmakar and the organizing committee for inviting me to present this fascinating topic. I have no relevant financial disclosures. The microanatomy of the brachial plexus is very well described, and I refer you to any standard textbook for this. There are, however, 3 recent microanatomy discoveries that potentially have a profound influence on how we do regional anesthesia that I would like to highlight. The first is the way that local anesthetic agents spread centrally and peripherally after intraneural injection. The second new development is the concept of the circumneurium, formerly known as the paraneurium, and before that the gliding apparatus of the nerve. And the third is the newly discovered and recently described circumfascicular collagen layer. So let us dig into this and start with central spread after injection into a root or trunk of the brachial plexus. And let us first look at some older concepts. What happened over the past 100 or so years? Now compare this Cordinier image of 1899 with the electron microscopy image of Reiner of 2016 and notice the obvious similarities. Doug Selander in 1978 showed that fluorescent dye injected into a fascicle under direct vision spread centrally inside the fascicle. And he demonstrated the dye subpareal in the spinal cord. He postulated spread via the fascicle that basically agrees with the findings of Danny Moore in 1952, where he injected India ink under direct vision into the intercostal nerve of rabbits and showed spread to the spinal cord. He attributed this spread to the presence of paraneural spaces in the endoneurium of the fascicle. He was the first to coin the phrase paraneural spaces, a concept that remained in the mainstream of our pool of knowledge for well over 60 years. In his textbook of Complications of Regional Anesthesia, he stated that intraneural injections may be dangerous, not only on the basis that they may cause nerve damage, but because solutions injected intraneurally may reach the subarachnoid space or the spinal cord via the perineural spaces of the peripheral nerves. And he said the perineural spaces of the nerves are actual, not just theoretical avenues to the spinal cord when solutions are injected intraneural. And even in Reiner's 2016 atlas, some, including yours truly, believed that the perineural spaces could be seen outside the myelin sheath in the endoneurium of the fascicles. What we at the time thought were perineural spaces could comfortably explain central spread. Untold Professor Rayner himself demonstrated that these spaces that looked like perineural spaces were in fact artifacts caused by the preparation of the electron microscopic specimens. Let us now look at some new concepts of central spread. We now know that there are 6 avenues for intraneural injected fluid to reach the central nervous system. The paravertebral nerve roots of the cervical, thoracic, lumbar, or sacral spine brings a sheath of meninges with it for varying distances. And Moore in 1952 and Labat in 1923 aspirated CSF from these subarachnoid spaces during attempted supraclavicular blockade. We can reach the spinal canal by any of the 6 avenues shown here in this Mary Bryson drawing. N1 is a subarachnoid injection, typically steroids injected into the neuroforamen with no serious consequences. N2, on the other hand, into the parenchyma of the nerve root or trunk, resulting in delayed respiratory arrest and severe neurologic deficits. N3, extra or epidural injections, typically when a large bore TUI needle is used, leading to a perfect nerve root or trunk block. N4 depicts a subarachnoid injection with immediate respiratory arrest and no neurological deficit if properly ventilated. N5 is also a subarachnoid injection into a paraneural cyst or arachnoid villi with similar effects as N4. N6 is a subdural but extraarachnoid injection leading to the so-called massive epidural. Perhaps this yet unpublished personal series from my medical legal practice in the USA illustrates this best. I was an expert witness for the defense of 14 cases of devastating or potentially devastating complications after interscalene or cervical, thoracic, or lumbar paravertebral blocks. And remember, an interscaling block is a cervical paravertebral block if done on the root or even in some patients on the trunk level. It was possible to allocate the patients into 2 distinct groups, and we added a 3rd group from our own clinical practice. Group 1 had 6 patients with late, after 20 to 30 minutes, respiratory arrest. All 6 these patients presented post-operatively and were mechanically ventilated for 5 to 10 hours and had significant permanent neurological deficits after 6 weeks that varied from monoplegia to quadriplegia. Group 2 had 8 patients with immediate respiratory arrest. All 8 these patients also required 5 to 10 hours of mechanical ventilation, but none of them had any neurological deficit, and all 8 made a complete recovery. There were 3 patients from our own group over a period of 12 years where 18-gauge TUI needles were used for the block. The needles were opened to ambient pressure and CSF was noticed at the needle hub. It was regarded as dural punctures and the needles were removed and replaced at a higher level and no neurological or other sequelae followed. All the blocks done for the patients in Group 1 and Group 2 where they had delayed or immediate respiratory arrest had this closed syringe tube thin sharp needle combination in common. With this needle, the dura and arachnoid of the dural sleeve can easily be punctured, And as we know, the aspiration test is totally meaningless because the suctioning draws tissue onto the needle opening and obstructs it. And even if CSF were aspirated, it would be mixed with the clear fluid in the tube and syringe and thus not be recognized as CSF. The patients in group 1, those are the patients with a late delayed respiratory arrest, all had significant serings formation on MRI after 6 weeks. What happened here? In the patients in group 1, the needle was placed inside the parenchyma of the nerve roots or trunk at the N2 level here. Spread was central between the fat cells and the perineural cells of the nerve fibers and needed to first diffuse through the Pier before reaching the CSF to spread cephalad to reach the respiratory centers. This spread over the Pier took some time and accounts for the delay in the respiratory arrest. The neurological deficit that followed was a function of the size of the serings, which in turn was a function of the volume and the pressure of the injectate. We do not know if the nerve damage is due to local anesthetic toxicity or whether it is due to the pressure and subsequent ischemia. The needle for the blocks in group 2 were placed subarachnoid at N4 or N5 and the CSF backflow was not noticed. The entire dosage of local anesthetic was then injected intrathecally deep to the arachnoid with immediate respiratory arrest due to total spinal block that lasted as long as the local anesthetic lasted. In group 3 patients, the dural and arachnoid punctures were immediately identified and no agents were injected at the site. They were regarded the same as any other accidental dural puncture. This is a patient from my own practice for whom I performed a lumbar paravertebral block. I placed an 18-gauge TUI needle open to ambient pressure and connected to a nerve stimulator using Capdevilla's landmark some 1.5 inch from the midline. CSF freely flowed from the needle hub as soon as the motor responses were observed. The needle was withdrawn and replaced a segment higher with no further consequences. Now, how does local anesthetic, or any other fluid for that matter, spread in peripheral nerves? Here are some older concepts. The prevailing wisdom as recently as 2018 was that intravesicular injections were possible and that it was responsible for nerve injury. Spread after intraneural injection has always been believed to be subperineural, subepinural, extraneural, or subparaneural or subcircumneural. This animation demonstrates the prevailing opinion as recently as 2018. Spread is via the endoneurium of the fascicles, number 1 in this drawing, and of course in the adipose tissue of the subepinural space, number 2. Let us now look at some newer concepts of intraneural spread in peripheral nerve. In this paper from our group from the Reiner laboratories in Madrid, we introduced a novel marker we called heparinized blood solution, HBS, to histologically follow the spread of a solution deliberately injected into nerves. We use this marker because it stays in the compartment into which it has been injected and does not cross barriers. With this solution, we were able to show confidently that intraneural spread was only possible between cells. the cells of the perineurium and fat cells, and only between cells and nowhere else. In this study, that was published in 2019 in Anesthesiology, it may, under low magnification, look like intrafascicular spread was indeed possible, as can be seen on this image. However, it was clear on high magnification that the spread was between the cells of the septae that were formed by the perineurium. As hard as we tried and failed to inject into the fascicles, this study led us to conclude in 2019 that spread was not possible inside the endoneurium of the fascicles, and that there are without any doubt no perineural spaces in the endoneurium that allowed for the spread of local anesthetic agents. The only spread was between cells, again the cells of the perineurium, and the fat cells, anywhere where fat cells may be. Let us now have a closer look at the circumneurium, previously and still sometimes today referred to as the paraneural. This membrane, first known as the gliding apparatus of the nerves by neurosurgeon, was described in 2012 by the Anderson group. The anesthetic implications of it was quickly realized, as not even methylene blue could penetrate this membrane. It would thus take a high concentration and large volume of local anesthetic agent to obey the Fick principle of diffusion to reach the axons of a nerve if the drugs were injected or infused outside the sheath to reach the axons of the nerve. The Anderson group named this the paraneurium, which is obviously etymologically incorrect, as para refers to beside, alongside, beyond, or next to. It has later been renamed the circumneurium, as the prefix circum originates from the Latin meaning around, as in circumcision. The excellent work of Manoj Karmakar and his team was quick to identify this membrane with high-definition ultrasound. First, in the sciatic nerve, as shown here, and then later in the brachial plexus, and shown by the arrowheads in this ultrasound image. I have to caution that the circumneurium at this stage of our development can only be visualized with high-definition ultrasound and not with regular garden variety ultrasound. Our Madrid group followed by showing the circumneurium microanatomically, and it was quickly realized that it forms a formidable barrier to the diffusion of local anesthetic agents to reach the axons of the nerves, because it is also formed by interlaced collagen fibers. We also showed this membrane in the higher parts of the brachial plexus. The circumneural and epineural interlaced collagen fibers are shown in green in this photograph. I have to point out here the position of the phrenic nerve on the belly of the anterior scalene muscle. Note that it is outside the circumneurium of the brachial plexus, and drugs injected or infused deep to the circumneurium of the brachial plexus would very unlikely be able to reach the phrenic nerve. We now think that phrenic nerve sparing is more a function of where in relation to the circumneurium the drug has been injected, rather than the volume of the agent. This image from the Rhina Atlas shows the white arrows that point to the circumneurium and the green arrows pointing to the epimysium around the muscles. We can easily see how an injection between the circumneurium and the epimysium in the white spaces here has a clear and easy passage or pathway to the phrenic nerve. So what are the clinical implications of this? If we look at this image from the work of Admir Hatzig, we can clearly see the free spread of contrast medium to include the phrenic nerve when injected into the space between the circumneurum and the epimysium. If it were injected or infused deep to the circumneurum, the spread would most likely have been limited to the 3 roots and not to the phrenic nerve. Although this is not yet proven by formal research, it is certainly been our experience over many years and many thousands of injections and continuous infusions that injecting or infusing local anesthetic agents deep to the circumneurum lead to low incidence of phrenic nerve block, low incidence of primary or secondary block failure with continuous block, and lower volumes of local anesthetic agents required for blocks. The third potentially important development as far as the microanatomy of the brachial plexus is concerned is the recent description of the circumfascicular collagen layer. Out of ignorance in our original description in 2020, we named it the internal epineurium. This is obviously a misnomer because something cannot be internal and have the prefix epi. We subsequently, in a letter to the editor of RAPM, proposed to rename it the circumfascicular collagen layer. What is unique about this layer is that it does not contain any cells. It is only made up of interlaced collagen fibers, and it snugs up right against the perineurium of the fascicles shown here in blue without any adipose tissue separating the two. As we know, the perineurium consists of cellular tissue with nuclei and thus mitochondria and DNA that can create new proteins. This creation of new proteins is regeneration, and we also now know that it is under the control of electron transfer, that is, electrical current. This is a photograph of a larger magnification of this layer shown in light green, snugged up to the blue cellular perineurium. And now we get to an area where we perhaps have to apply a little philosophy and speculation. We have to look at the groundbreaking work of Robert Becker, an orthopedic surgeon who in 1984 published this book that fundamentally changed our thinking of electron transfer in the body. He worked mainly on salamanders and frogs and was fascinated by the regrowth and healing potential these animals have. If amputated, they can regrow a limb or a tail or even parts of their heads. As we know, the impulse nerves of the brain and body are digital. We all remember the all or nothing principle of nerve conduction. Becker discovered and described an entire second nervous system of fibrous tissue surrounding nerves, which he named the perineural system. And he showed that it is an analog system of continuously varying strength, direction, and waves of strength. But Becker unfortunately died in 1989 and could not show it definitively under a microscope. This book is a must-read, but he basically concluded that this second nervous system controls growth, healing, and biological cycles. Extensive research is ongoing following this work of Becker. We always thought that fibrous tissue serves only as structural support. Becker, however, showed it also serves to conduct electrons, in other words, electricity. It has the lowest electrical resistance of all tissue in the body, and it is a semiconductor. In other words, it only allows flow of electrons in one direction. Becker never realized the fibrous sheath forming the perineural nervous system was actually bringing in electrons to change the voltage from operating voltage to a healing voltage. The big question now is if this circumfascicular collagen layer is perhaps that fibrous tissue that conducts the healing voltage that Becker was talking about. And certainly future research will clarify this for us. I again thank Professor Karmakar for inviting me to present this topic, and you will see that I slightly changed the heading. And I leave you with the thought of perhaps considering the newer microanatomy in your clinical practices when performing regional anesthesia. I thank you very much for your kind attention.
Thank you, Andre. That was a truly wonderful presentation. I hope, ladies and gentlemen, you're slowly now settling into this session. How good was those two sessions by Georg and Andre? I think as far as I'm concerned, I'm kind of intimidated because it's a difficult act to follow, but I try my best to keep you guys thrilled and entertained. Now, my job is to now produce or to develop in you a clinical correlation of the anatomical, the microanatomical facts, and try and demonstrate to you that the circumneural sheath is it a reality or is it just a myth that you can see in histological sections? And does it really play a part in our what we do during regional anesthetic blocks, particularly in the brachial plexus? So I will focus mostly on the brachial plexus during this session. Right, yo. Okay, I have no conflict of interest to declare. However, in the interest of clarity during this presentation, I have taken the liberty to present some unpublished data, which I think is important because otherwise it kind of leaves a gap between our understanding, but I'm happy to do that. I urge your caution in your interpretation. Also, whenever you see a red star, that means it's an important take-home message, so do pay attention. My objective is to review briefly the concept of the brachial plexus sheath that we sometimes very commonly use in our practice and often described as injection deep to the brachial plexus sheath or extrafascial, subfascial, so on and so forth, including me. Then I'll try and demonstrate to you what the paraneural sheath of the brachial plexus is, and is it really a structure that you can delineate in clinical practice, and provide you some tips and tricks that may help you to try and define this structure and perform regional anesthetic blocks of the brachial plexus deep to it. As Professor Boezaart already mentioned, alluded to in his talk, that if you inject outside this sheath, the fixed principle of diffusion may find it hard to deliver optimal concentration of drugs to the site of action, which is the neurons. And then we discuss some clinical implications of this structure. Now, although the discussion is about high definition ultrasound, today there are various different equipment available in your armamentarium. I have to say that while high definition ultrasound gives you better resolution and better capability, but I think sometimes the lack of definition is between the 2 ears. There's often a saying, if your mind doesn't know, the eye does not see. So rather than blame these garden variety machines, as, if I may use the word that Professor Boezaart used, it is, ask yourself, is it the machine or is it you? Nevertheless, we use these high-end equipment, but this is based on research equipment grants that we acquire from the university. So I have nothing financial, of any financial interest to the companies that I may be using equipments of. Today, it has indeed become an integral part of our clinical practice, as you see. When we come in the morning, it is part of our armamentarium. I envision one day it will be part of one of these panels, and it's only a matter of time that these providers will come to some financial agreements and it'll become integral part of your anesthesia machine. Now, when we look at the concept of brachial plexus sheath, actually Professor Alan Winnie described it way back in 1979. He described this as a tubular structure that extends all the way from the roots of the brachial plexus, from the cervical vertebra all the way down to the axilla, where he hypothesized that if you place your needle deep to this tubular tunnel anywhere along its course, you can get brachial plexus anesthesia. So this was a perivascular or a paraneural conduit that was the concept, and brachial plexus sheath was a tubular prolongation of the deep cervical fascia. Subsequent many research publications in our most esteemed journal, Anesthesiology, by Thompson and Rory, and then more later on by Partridge and Birkenstake, they demonstrated that the brachial plexus sheath was indeed a structure that enveloped the elements of the brachial plexus, until Professor Philip Cornish from New Zealand actually challenged this concept and said that, is it really a fact or just a fiction? I think you have to appreciate that while the early researchers used CT with contrast injections to visualize the brachial plexus, today we know that there's a lack of resolution with this imaging technique. So maybe they were just imagining what was the brachial plexus. Cornish actually developed a new concept. He said that all these brachial plexus elements travel from its origin to the axilla or even beyond in intermuscular tunnels. So these are the neural tunnels, and there is no enveloping sheath. In fact, it's a rigid-walled tunnel formed by the muscles that surround the neural elements. As Professor Feigl mentioned, there is the interscalene gap, and later on you go to the in the costoclavicular space, you have the costoclavicular space between the subclavius muscle and the serratus magnum, or the upper slips of the serratus anterior, and in the axilla, and in the paracoracoid area, you can see it's between deep to the pectoralis major and minor, and between this and posteriorly, you have the subscapularis muscle. So the axillary tunnel became a concept where local anesthetic was injected, and Dr. Cornish went on to describe many supraclavicular brachial plexus technique. In a publication by Dr. Marimoto from Japan, I think it was during the time he worked in New York with Dr. Rosenberg, that in a case series he presented that he was able to delineate septae during infraclavicular brachial plexus injection. Although the resolution of this so-called phase array transducer is probably a microconvex transducer. You can see here, this is the subclavian artery, or the axillary artery more accurately. This is the second part of the axillary artery. You can see the posterior cord, the lateral cord, and the medial cord more posteriorly. And then it was Dr. Carlo Franco who, in this publication, demonstrated in very vivid illustrations the brachial plexus sheath. But really, ladies and gentlemen, is this really the brachial plexus sheath? Today we know that this is indeed not the brachial plexus sheath. It's not as simple as just exposing the neck and injecting some saline deep to this fibroelastic structure, which was described as the brachial plexus sheath incorrectly by, if I may say so, by Professor Paulo Franco. And as Dr. Feigl has already alluded to, that this is indeed the deep cervical fascia that lies superficial anterior to the brachial plexus. There's another very interesting publication. I think this is from Turkey by Dr. Sadan and his colleagues, where you can see here there are indeed many fibrous compartments that are indeed occupied by the individual nerves. And they hypothesized that, or they, based on their observation, mentioned that it is indeed these fibroconnective tissues that form compartments within the axillary sheath or the brachial plexus sheath that, and that's why you need multiple injections when you perform brachial plexus in the axillary, by the axillary approach. They also demonstrated these are actually fibro connective tissue. You can see here they are transparent if you illuminate some light. And after you inject, they usually form some blebs that you can see in this image to the right, where they are seen as multiple blebs that usually give way when you inject large volumes of local anesthetics. John Dolan, in this publication in Regional Anesthesia Pain Medicine in 2009, demonstrated the same septum that Dr. Marimoto had previously demonstrated a few years ago. You can see here, this is lying on top of the axillary artery. And after you inject local anesthetic or some saline, you can see demonstrated that this indeed impairs the passage of the local anesthetic from this superficial to the posterior aspect where the medial and the posterior cord are located. Brenner and their colleagues from Ireland in their cadaver dissection went on to demonstrate what they described as a fascial layer of connective tissue that actually surrounded the brachial plexus along its course in the infraclavicular area. As you can see, the structures that are labeled as F are indeed the fascial structures. And he also demonstrated or interpreted that some of the injectate was impeded by these so-called fascial connective tissue to the various elements of the brachial plexus. Then came Dr. Feigl, who in a letter to the editor in the British Journal of Anesthesia illustrated the same figure you are very familiar with today. He said that it is the prevertebral fascia which has been misinterpreted as the brachial plexus sheath. And the prevertebral fascia continues as the clavipectoral fascia. In fact, the clavipectoral fascia continues with the fascia surrounding the subclavius muscle, and then it goes on to envelope the pectoralis minor. And if you go more towards the axilla, it then forms the fascia of at the base of the axilla, and then it continues towards over the brachial plexus as the deep axillary fascia. And today we've been given a real feast about the dissections of this fascial layer and how it's also in this review on the anatomy of the brachial plexus. We have now come to know that, in fact, what was once misinterpreted as the brachial plexus sheath is indeed the prevertebral fascia in that interscalene gap, and is labeled as this green dotted line on top of the scalenus anterior and the medius. The scalenus anterior is to your right at the interscalene groove, and this is at the subomohyoid level at the supraclavicular fossa. You can see this dotted or this broken green line is indeed that brachial plexus at the deep cervical fascia, and there are no indeed connective tissue layer that actually surrounds the brachial plexus elements as the brachial plexus sheath. Again, in the axilla, the same. You can see here, it is a deep or at the infraclavicular area. You can see here, this is the clavipectoral fascia, which now takes the role. and deep to it lies the elements of the brachial plexus, or the cords of the brachial plexus. Further down in the axilla, and George has already demonstrated that to you very clearly, it is indeed the deep axillary fascia that forms this fascial covering of the neurovascular elements at the axilla. More recently, Enrico Munzo and Dr. Reyna's group demonstrated with some histological correlation of that septum that was previously being discussed about. They demonstrated again that there is indeed a septum that separates the lateral cord from the deeper medial and the posterior cord. You can see here, this is the axilla. This is in the costoclavicular space. So the lateral cord is always anterior, or the medial cord is dorsal to the lateral cord, as Professor Feigl already alluded to, and the posterior cord is usually lateral to that. It places the needle deep to the pec major, and I believe this is the subclavius muscle, or this is, and then they found there's a septum. You injected saline, it actually remained within the anterior part of this anatomy, and then once you punctured this structure, they often felt a haptic sensation, and when you injected local anesthetic, you could see now spread to the medial and the posterior cord. Thereby, they went on to conclude that this septum may play a role in clinical efficacy by limiting spread to the medial and posterior cord. They also concluded, based on these correlative histological images, that this septum is indeed a fused septum of the circumneural sheath of the medial and the posterior cord. As you can see here, it's a multi-layered, is interlacing. It contains collagen fibers, and this has been discussed in the previous presentation. And the image to the left, you can see here again, it is interlacing. It has collagen fibers, and they form a dense network. And I will come to that more in detail in a short while. It was until this publication by Dr. Anderson, there was not much reference to this in regional anesthesia. This group from Scandinavia demonstrated that macroscopically and microscopically that this paraneural sheath, or the circumneural sheath, is indeed macroscopically and microscopically separate from the epineurium of the nerve, and this circumneural sheath indeed surrounds the neural structures which was the sciatic nerve in the popliteal fossa. They also demonstrated that injections outside and deep to this sheath produce different sonographic appearances. Also in cadaver dissections, they demonstrated that an injection outside the sheath is usually localized to the area of injection, whereas an injection deep to the sheath, or if we refer to this as subfascial, spread extensively along the sciatic nerve and stained the sciatic nerve for great lengths along its path. And when you dissected it out, it was separate from the epineurium of the nerve, as you can see here, that it indeed is not part of the epineurium. It is the neural structures, or the neurons inside the epineurium, are indeed not stained in this case. It's not an intraneural injection. This is during my visit to Barcelona, where with Dr. Salablanche, we did this cadaver dissection. And you can see here, Dr. Salablanche has very eloquently demonstrated that this circumneural sheath is indeed very elastic. It is a thin, transparent layer, which is, and histologically is a collagen fiber, is interlacing, and indeed also has fatty tissue. And I will come to that in a short while. It's been known as the gliding apparatus, as Professor Boezaart has alluded to, but actually it's also in anatomy and physiology, it's often also referred to as the mesoneurium, or a structure that is outside the epineurium of the nerve, the connective tissue layer. Recently, using high-definition ultrasound imaging, we reviewed some of our work that we had done with costoclavicular brachial plexus block to try and see if we can define this so-called connective tissue layer that surrounds the brachial plexus element. Now, if you understand the anatomy of the costoclavicular space and the cluster of nerves that are located within the costoclavicular space, then if there were a circumneural sheath then any injection that we perform at the center of the nerve cluster within the costoclavicular space is a subfascial injection. So in principle, a costoclavicular injection is a subfascial injection. And we had demonstrated earlier in the popliteal fossa that the circumneural sheath is quite difficult to delineate before the local anesthetic injection, even with high definition ultrasound. Maybe in 10, 15% of individual, you can define it. But in majority, it's usually pops up as soon as you inject some fluid or local anesthetic. So with the same principle, we went on to review about 100 of our cases that we had done on the costoclavicular brachial plexus block. I'm just going to highlight some of the images that we were able to define. You can see this is a patient anatomy of the costoclavicular space. To your left is lateral, to your right is medial. So you can see the axillary vein, the first part, with the axillary artery, pulsatile, and the neural cluster that is located lateral to it. So the muscles you see on the anterior aspect is the clavicular head of the pectoralis major. The subclavius muscle is this long elongated muscle. And deep to it is the upper slips of the serratus anterior lying on top of the second rib. I agree with Professor Feigl that there's many misinterpretation of this being defined as the second rib. Actually, the second rib is very difficult to define with ultrasound. It's actually deep inside that is often not accessible. So it can be an important landmark when you do some of these pectoral injections, where you're looking for the fourth rib or the fifth rib. You identify this as the first rib, then you are obviously you're incorrect in your identification. Anyway, coming back to where we are, this is indeed the lateral cord, and posterior to that is the medial cord, and lateral to that is the posterior cord. You can see there's a well matrix of fibrophatic connective. These are in fact adipose tissue between the nerves, and superficial anteriorly you can see this epimysium, which is this very bright structure of the epimysium of the subclavius muscle. But deep to that, you can define that there is another structure which is between this hyperechoic and the hypoechoic fat-filled area. It's probably the circumneural sheath. And this can be defined not only on the anterior aspect, but also on the posterior aspect of this neural cluster. So we believe this is the paraneural sheath that surrounds the brachial plexus elements, the cords of the brachial plexus at the costoclavicular space. Now, as we all understand, as we all know, the cords of the brachial plexus take on an arrangement like so in the costoclavicular space, but as they descend towards the infraclavicular area or the lateral sagittal infraclavicular area, and in the axilla, it gradually rotates itself into its position that is often described in the literature. It takes on a position in the second part, which is deep to the pec major and minor, with the medial cord being between the axillary artery and the axillary vein, the posterior being posterior, and the lateral being more towards the superior aspect. However, there are a lot of anatomical variations in this area, and the position varies with the position of the arm. You must remember that. Now, this is an image that Dr. Boezaart has already shown you, but this is a video of the same. You can see here, this is the nerve cluster. You can see the lateral cord, the medial cord, and the posterior cord, and we place the needle in plane at the center of the cluster, and we inject the local anesthetic. You can see that the circumneural sheath is indeed containing the local anesthetic like a want of a better word, maybe it's like a circular sausage. You can see a structure here where it's indeed containing the local anesthetic within this. Although it contains it for a while, after a while, you'll often see that it leaks out. So although the circumneural sheath is a well-defined sheath, I don't think it can hold on to the resistance offered by increasing volumes of local anesthetic, so much so that it tends to leak out, as you will see. So we can see here now, there is a local anesthetic within the costoclavicular space and deep to the circumneural sheath, and with the cords basically bathed in an ocean of local anesthetic. Indeed, we only inject between 20 to 25 mils of local anesthetic, a 0.5% ropivacaine, levobupivacaine in our clinical practice. So you can see here, it produces quite a significant expansion of the circumneural sheath in this area. Also, it's important to understand today when having correlated these sonographic images with the microanatomical sections from the Professor Reyna's laboratory in Madrid, we can say that this is indeed an all-inclusive neurovascular sheath. So it not only includes the cords, but actually it encompasses also the axillary artery and the veins in this particular location. So the concept should be that it is indeed a all-inclusive neurovascular sheath. Also, we have in our review, we've also identified that once you inject the local anesthetic, it becomes much better delineated. And this is the septum that Munzo and Marimoto and Dr. Dolan and them have alluded to in their previous publication. You can see here, if this were to be the circumneural sheath, you can see here now there is leakage of local anesthetic into outside the circumneural sheath in the costoclavicular space, but it seems to be an all-inclusive sheath. It divides this circumneural sheath into an anterior and a posterior compartment. This is very consistent, and I will show you more images relating to that. In the anterior compartment is located the lateral cord, and in the posterior compartment is located the medial cord, which is very arterial, just next to the artery, and the posterior cord is the one that is lateral. So this is quite consistently identified. You can again see here, this is the lateral cord here, the septum, and the anterior and the posterior cord. So this is the circumneural sheath with the three cords, the neurovascular structures, and you can see a septum bisecting this entire circumneural sheath. When you correlate this with the histological images, and you can see on your top is the stained images without labeling. We have labeled them just for clarity. You can see here these green collagenous layers actually surround the artery and vein, and it also is very well organized where the cords are located, but less organized away from it. Is indeed an all-inclusive, and in between the cords, they come together and often fuse to form the septum between the lateral cord, medial cord, and the posterior cord. So this is what we believe is the septum now. This is one of my best images that I have been able to present to you, although I have had many other such successes, if I may use that word. You can see here, this is indeed the second part of the axillary artery, deep to the pec major and the minor. So this is below the costoclavicular space in the infraclavicular fossa. You can see the lateral cord in the anterior compartment is actually surrounded by local anesthetic. And deep to it, you can see the medial cord and the posterior cord. And I think, as George mentioned, you will see more than two. In fact, there are many here. And I think this is where they're all starting to give up the muscular branches and some of the divisions that we are all familiar with, including the lateral cord you can see here is giving out some branches. And you can see here, this is, note the compartments. You can see these arrowheads actually represent the circumneural sheath. In fact, the septum is the short arrows you can see going through. And now, having seen it in the costoclavicular space and now at the lateral sagittal infraclavicular fossa, you can see that it is probably an extension. So what you see in the costoclavicular space extends down to towards the infraclavicular and then eventually to the axilla, creating these two anterior two compartments where you start to think now where local anesthetic is injected, and then it may play a part. In fact, it is not a flimsy membrane. You can see it's a very well organized. I think this organization comes after you inject the local anesthetic. Usually in that space, you have collagen fibers, you have adipose tissue, you also have blood vessels. And once you inject the local anesthetic, they all coils together, form what would appear now as a well-defined septum. But actually, it is a composite image of all these structures that are indeed within this septum. As you will see here, This is again a correlative histological image from the lateral sagittal infraclavicular fossa. You can see here the lateral cord, the medial and the posterior cord, and the septum, which is this number 13, is the septum that comes together once you inject the local anterior or posterior to this. This is better defined in the further down as you go into the proper lateral infraclavicular fossa. You can see the circumneural sheath and the anterior and the posterior compartment. This is another image from the lateral sagittal infraclavicular fossa. You can see this septum very well defined. It is indeed extends from the axillary artery onto the lateral aspect. And anteriorly, you can see the anterior compartment, which contains the lateral cord, and the posterior compartment that contains the medial and the posterior cord. Again, this is another image for you from the lateral sagittal infraclavicular fossa. And we are all familiar with the scan here with the arm abducted in this case. You can see here that you can see a very well-defined anterior compartment and a posterior compartment. And this is where the medial cord is now attaining its so-called well-defined position between the axillary artery or close to the axillary artery and the vein, where the posterior cord takes on the posterior relationship. Again, this is a same histological image to show you how the nerves rotate to take up their position in this. So the circumneural sheath in these histological images are indeed interlacing. There are multiple fibrous structures here. They are all collagen fibers. Indeed, in some of the histological images relating with the sciatic nerve, you can see there are many adipose tissue here, but you don't see any adipose tissue. But it's possible that there are some adipose tissue within it, because you can see it in cadaveric dissection when you scan the circumneural sheath that surrounds the sciatic nerve, that it indeed, it's a very thin membrane, but it is laden with a lot of fat tissue that are coalesced as you inspect this structure. So indeed, ladies and gentlemen, it is fair to say that the brachial plexus sheath does not exist. It is indeed a misinterpretation of the deep cervical fascia, or the prevertebral fascia that surrounds is anterior to the cords. It is also sometimes you can see here that there are well-defined compartments. Today we are able to define two compartments, an anterior and a posterior compartments. And I hope I've shown you enough, convince you that they exist in the infraclavicular and costoclavicular area. You can see here, this is intermediate in between the infraclavicular and the axilla. Here you can see all the nerves are starting to give up the branches, and the anatomy appears a little different. But again, here you can see it seems to be compartmentalized, and the nerves are well defined in their individual compartments, as you can see here. So this is a sequence from a same individual, and you can see here how, once we've done the costoclavicular brachial plexus block, you can see how the circumneural sheath pops up to life, and you can now see it. And the septum can also be defined. You can see the compartments, anterior and the posterior, and the various cords that are in relation to these anterior and posterior compartments. So what do we know so far? As I alluded to before, brachial plexus sheath is often a misinterpretation of the prevertebral fascia, or indeed it could also be a misinterpretation of the circumneural sheath, because at the time we were referring to a sheath, but it could have very well been the circumneural sheath that we were not familiar with at the time. In fact, the circumneural sheath is not a myth. It is indeed a layered. It is indeed a reality. It is, as I demonstrated to you, it's a multi-layered, interlacing, fibrofatty, collagenous tissue that surrounds these neural elements. It is also an all-inclusive neurovascular sheath. It is septated, forming various compartments for the nerves. At the costoclavicular and in the infraclavicular today, we are familiar with two compartments. Now, the natural question would be, do they have any clinical implication? Today, they are a paucity of data. Now, I'd like to pause here for a moment, because it's been a while since I've really seen a golf course. and more importantly, seen a beach. This is a picture that I can attest to and I can relate to. It's a picture from beautiful Bali in Indonesia. The name of the golf course is Nirvana. It's truly nirvana in many ways. Let's move on. So the circumneural sheath, what are its clinical implications? Today, there is a paucity of data. It's not known if it affects sensory motor blockade during a brachial plexus block, although there are many reports that it may affect local anesthetic spread during a brachial plexus blockade at the costoclavicular space or at the lateral sagittal infraclavicular space. However, as we have mentioned to you, that subfascial injection does affect popliteal sciatic nerve blockade, and I will discuss more about this in my presentation after the break. It actually, to summarize it, subparaneural or a subcircumneural injection or a subfascial injection at the popliteal fossa fastens the onset. It prolongs the duration of the block. But what about subfascial injections in the supraclavicular or costoclavicular area? Now, if many of you are probably not very familiar with this, I was in India in a fishing trip in somewhere close to Mysore, and I saw this king of the road, as I often say. This is the king of the road in India. Many of you in the British Isles will refer to this as the Morris Minor, but this is the ambassador. But slowly, it's being eliminated from the roads of India because more cheaper, expensive cars are now the norm. Anyway, this is a work that I was involved with Dr. Siva Shanmugam and the group. In fact, we investigated whether an extrafascial or a subfascial injection in the supraclavicular fossa makes a difference. In fact, I think it's fair to say here that what we thought was the brachial plexus sheath, it was indeed today known as is probably the circumneural sheath. However, I think irrespective of what it is, but you can see here that there are two patterns of spread that emerge when you perform an injection outside and inside the sheath. You can see here, this is the cluster of trunks and division anterolateral to the subclavian artery on top of the first rib at the supraclavicular fossa. You can see here, when you inject some saline outside this so-called sheath, you see that the neural elements are in fact displaced anteriorly or more medially towards the vein. You can see here. In contrast, when you place the needle into the connective tissue matrix between these neural elements, you can see that there's separation of these elements, and then you can start to see these the sheath that surrounds these elements in the supraclavicular fossa. Dr. Shanmugam concluded based on his results that time to readiness, or in fact, the onset of sensory motor blockade was much faster, and the duration of a brachial plexus blockade with the supraclavicular approach was significantly longer when you performed a subfascial injection. I think the results are fairly fair. But what do you do? And how do you do a subfascial injection? Now, this is a high-definition image of the supraclavicular, ultrasound image of the supraclavicular fossa. You can see you can see the subclavian artery, and lateral to that and anterior lateral to that is the trunks and divisions of the brachial plexus. You can see the suprascapular nerve, which is just below the omohyoid muscle here. You can see the posterior and the anterior division of the superior trunk, the middle trunk, and the inferior trunk. So how do you do it? Well, today there are no well-defined techniques, but I would tell you this is a very simple approach that you can practice in your clinical practice. This is a simple saline hydrodissection approach. You can see here, this is not the circumneural sheath, ladies and gentlemen. This is indeed the prevertebral fascia that we are now separating as a hydrodissecting it from the muscle. And then once you penetrate it, you enter the neural elements, which would be like you put an intracluster needle and you inject. Now you can see that the neural elements separate out and the local anesthetic spreads within it. So try and use hydrodissection in your clinical practice, And as I mentioned, subfascial or subcostoclavicular injection is inherently a subfascial injection. So when you place a needle at the center of the nerve cluster, as you see here, this is the lateral cord, this is the medial cord, and this is the posterior cord, and you inject the local anesthetic. You can see in real time there's distension of the space, including the paraneural structures. And as I've demonstrated to you before, the circumneural sheath sometimes pops into life, and you can see it. Seeing the septum is not that clear in most cases, but occasionally you will see it. So the clinical implication today is that there is indeed a paucity of data. Indeed, the costoclavicular block is indeed a subfascial injection, and they are suggestions that two injections, one in the anterior and one in the posterior compartments, would be desirable. In fact, this is a work by Dr. Laera and the group from Canada, where they performed indeed two injections, as you can see here. One was lateral to the lateral cord here, and another one on the medial aspect, medial to between the artery and the medial cord. Actually, the logic of this injection is not known to me, but I think this is somewhere I would not go and place my needle. But anyway, they looked at the time to achieve a composite score of 14 in the 4 nerves. And they found that initially there you can see here, this is the costoclavicular is the one in dark bars. You can see here that indeed in the initial part there is a difference, but at 30 minutes there's no significant difference between the number of patients who achieve this composite score. So you may see an early improvement in sensory motor, so earlier onset of these blocks, but within 30 minutes, they usually no difference. These investigators from Korea, Dr. Lee and the group, performed indeed triple injection. And we've also completed some data collection in this area with 3 injections, and we will be sharing it. This is actually quite similar to the previous study I mentioned with 2 injections. However, these investigators found that number of patients who developed complete sensory motor blockade of all the 4 nerves were better in the 3 injection group. Now, this is, you can see here, 85% versus 53%. They are significantly different at 30 minutes. So with respect to the circumneural sheath of the brachial plexus, I may conclude that the concept that the brachial plexus sheath exists is not true. It's a misinterpretation of the prevertebral fascia, or often the circumneural sheath that we are now becoming familiar with today. The circumneural sheath is an all-inclusive neurovascular sheath that is a multi-layered, fibrofatty, collagenous connective tissue layer in histological images. The circumneural sheath is also septated and compartmented, and it contains compartments. Today, there is a paucity of data on how this may influence clinical efficacy. We've only been talking about single shot injections. Imagine you place a catheter. Now you are in a dilemma. Where should you place the catheter? Should you place it? There's no denying you should place it subfascially, but where? In the anterior compartment or the posterior compartment? Especially when you're going to inject small doses of local anesthetic infusions in the post-operative period. So targeting the individual element that would be more desirable for your analgesic target would be maybe my way to go based on this understanding. Okay, I take this opportunity to thank you all, ladies and gentlemen, for your attention. Now, since we finished these 3 presentations, I would like to now invite the other speakers, Georg and Andre, to join me in the panel to answer any questions that the audience may have. Christine is one of my consultant colleagues at the Chinese University of Hong Kong, Prince of Wales Hospital. She's our moderator today. She will moderate the questions, if there are any questions.
Yes,
Christine, are there any questions?
Yes, and I think Dr. Feigl has kindly answered some of them already, but I think the other panelists probably can also give us some thoughts on these questions. So the first question is from Dr. Muthukumar Rajagopalan. So his question is there a chance of nerve injury in an attempt to inject LA into the circumneural sheath?
Andre, there's a question to you.
You know, the whole question of intraneural injection has changed probably in the last 3 years. And yeah, intraneural, I am not sure what is meant by intraneural. We used to think that was into a fascicle. We now know you cannot inject into a fascicle. It's pretty impossible. Then we thought it was deep to the epineurium, and that gives you a great block, and it gives you an immediate block, and we try to avoid that. But deep to the circumneural, if you look at the femoral nerve, for instance, it's not one nerve, it's 8 nerves, and they are all surrounded by this circumneural. And if you now put your needle or catheter deep to that circumneural, you are intraneural by definition, because the circumneural is what it says, it's around the nerve. So I don't know what the word intraneural means, but what I do know is that intraneural injections, if you define that as out inside the circumneural, there's no danger of nerve injury. If you inject it deep to the epineurium, your needle itself can actually damage the fascicles, and that is where the nerve injury comes from. It does not come from, or it can also come from a space-occupying thing that causes pressure and ischemia to that nerve. So I think the answer to that is it depends on your definition of an intraneural injection. But for me, an intraneural injection is deep to the circumneural, which is the ideal place to put an injection. And, you know, while I have the floor, so to speak, may I just say thank you, Manoj, for that brilliant presentation. And I'm so glad to see that we all three actually agree 100% on everything we said. I was afraid that you're going to stick to the term paraneural. Thank you for not doing that. And I was also afraid that you're going to say it's a nonsense concept, which is going to make us all pretty sad. But I thank you for that. And I must absolutely pay tribute. My talk is 100% Miguel Reyna's talk. He has to be accredited for all this work. My life changed when I picked up this book in 2017. That changed my life immediately, because we were always successful with catheters. And the reason we were successful with catheters, I never understood until I hold of this book. And now I know what happened there is that we placed, before ultrasound in the good old days, you know, when you and I were still young, we placed catheters, and these catheters always worked. They didn't have secondary failure rates. And the reason for that, that's before ultrasound. We placed a nerve stimulator on the tip of this catheter, and the catheter goes exactly where the local anesthetic goes. So if you subcircumneural, the catheter will stay subcircumneural, and that twitches, that whatever twitch it is, that is where your block's going to be. But if your twitches disappear, you go intramuscular or to some other weird and wonderful place. And that's why we used to be successful. Then came ultrasound, and we became very unsuccessful with continuous nerve blocks. And the reason for that is we've just mentioned them. We were outside that fascial sheath called the circumneural. Anyway, thank you. So if your definition is inside the circumneural, then absolutely there's no danger of nerve injury. Inside the epineurium, you can damage the fascicles with your needles. Certainly, if you into a fascicle, you've achieved something that we could never achieve, and that's to inject
Allow me to add a few words to Dr. Rajagopal's question. I think before we muster up a controversy here with our fraternity of regional anesthesia, I think let's keep it that the skin of the nerve is, take it as the epineurium. Although the circumneurum surrounds it, I think from a so-called danger point of view, it's the boundary would be the outer layer, which is the epineurium. In fact, the circumneurum is also an integral part of all nerves in the body. Now, while placing a needle deep to the epineurium is not desirable, not recommended, you may not find, even if you did, you may find that it may not always lead to a nerve injury, as is often mentioned. That does not mean that I'm condoning you to do so. Just remember that you must, as long as you can define that it and avert injecting large volume, then maybe you can avert long-term damage. That is again very speculative. However, now that our sweet spot of the nerve, and this is Dr. Boezaart's words again, if the sweet spot of the nerve were to be the deep to the circumneurum and outside the epineurium, and that's where we are injecting most of our blocks today. Somehow inherently circumneural, like I showed you, the costoclavicular space. Now, what I have found in most cases is now we are getting closer and closer and closer to the nerve. Patients will report a lot of paresthesia, often with the sciatic nerve blocks, and I will discuss more about this in the later session. About 60% of patients will often report paresthesia when you do these subfascial injections. Now, they don't usually lead to long-term consequences, but some odd patients may develop paresthesia, which sometimes they report even after 1 month or even later. Now, the exact reason for this is not known. And if you go by Dr. Barrington's data, it's often the surgeon to blame. It's often a surgical reason for this long-term neurological deficit. But we still don't know a lot about the long-term effects of subparaneural injections. Let's put it this way, in a very academic sense. George, do you have any comments?
Yes, I think I can pretty much agree with you both, because I think we talk about the same structures almost, and it's really depending on the definition and the terms we use. And that's causing some confusions because with all these different terms, I think we should sit together to a table to define new terms or anywhere to get one term for everything, what is used then all over the world. Anyway, I learned also today a lot about this circumneural sheath, and I pretty wonder where it is coming from. So this is something which is very important. Is it also a continuation or connection in between, for example, prevertebral fascia and epineurium or not? So this will be this is something for me which I want to investigate in the future time with some cross sections. And the second is that we have now these high resolution ultrasound images, as you showed it, Manoj. It was absolutely fascinating, and I think we have, we as anatomists have to go back to the labs and to take a look. What do we see in our ultrasound images? Because there is so much new visibility visible now, and we have no idea yet. So this will be
right, George.
that's so thrilling. I really look forward for the next 2 years or 3 years.
Yes, George, I think that's very true, because what ultrasound and high definition ultrasound is showing us is what macroanatomy did not show us.
That's it.
Either the preparation process, or when somebody is deceased, the structures degrade or they decompose at an early stage. But in vivo images in the living individuals, they are indeed there, and we have illustrated that. So I think this high definition ultrasonography is actually contributing to improving our understanding of the microanatomy at a microanatomic level.
Even more, you're absolutely right. I think the structure has been always there, but we have never looked at it. And now, as the clinicians find something, I say, come on, there is no spread to, for example, the medial cord, which is what's called the corner pocket. Well, why? Because of the septum in between. Okay, we have never took a look on that because it was, okay, no reason for that to find it or to search for it. And this is something
I will
which
remember
is
that one, George. Zuckerberg Thalander ligament, okay, the suspensory ligament.
Zuckerkandel sabilo.
Zuckerkandel sabilo ligament. Everyone, ladies and gentlemen, that is the word you must remember from today. Zuckerkandel sabilo ligament, and there are 4 of them. Okay,
6.
Christine, do we have? Christine, do we have any more?
Yeah, we have a couple of questions concerning costoclavicular blocks. I think a few of the attendees are particularly interested in putting in catheters. And because you've explained there is an anterior and also posterior compartment, and there is a septum in between. So a lot of attendees are interested in where exactly to put the catheter.
We will discuss more about this in a session dedicated to costoclavicular block, which is coming up in 2 weeks' time. But since you've asked the question, I'm happy to provide you some insight, but I can't give you any images. Now, because you see here, the nerves, the cords of the brachial plexus are very close to each other. Our original description was to place the needle at the center of the nerve cluster, if you may. So between the 3 cords. So we used to come from a we come from a lateral to medial direction, placing the needle through the gap between the lateral and the posterior cord, directing it towards the medial cord. So that brought the needle at the center of this cord cluster. And we deposited a single large bolus of local anesthetic that produced the primary block. Now, I, for one, when I place catheters, I use catheter over needle in most circumstances now, because I usually advance the needle tip to the point where I want to inject. And once I have distended, hydrodistended or distended that space with the local anesthetic, I usually don't advance the catheter anymore, and I just remove the needle or the stylet, if you may, and then attach it to the extension system that you're going to infuse the drug. So I usually still place it at the center. Now, whether this brings it to the posterior compartment or the anterior compartment, I haven't got no idea, because we haven't investigated on that. But however, when we look at patients in the postoperative period where they're receiving a much lower concentration and a lower volume of local anesthetic than your primary dose of the local anesthetic, we still find that fairly low concentrations or low volumes, we need something like 4 or 5 mils of local anesthetic. I mean, there haven't been times in my clinical practice when I have seen such low concentrations being able to be delivered to produce comfort. When I say comfort, it means the patients are comfortable with not only the block, but today we are also giving them a lot of multimodal analgesics in conjunction with this. So to answer your question, I think the center of the cluster would be a good starting point. It would be a good safe point. I could not recommend at this stage that you put it anterior, posterior. Now, these septum are existent, but to what extent they really impede the diffusion and the passage of the drugs from one compartment to another, it needs a lot of dedicated research to really answer those questions. But my gut feeling is, to give a large enough volume, then I think it can overcome all this. With time, the drugs, as the fixed principle says, it will diffuse over time and it will get to the sweet spot of that nerve. I hope that answers your question.
Okay. Thank you, Professor Karmakar. So there is another question concerning costoclavicular block. Probably will be covered in the next next week as well. So it's from Dr. Tony Ng. So for costoclavicular brachial plexus block, so for those with small body build and relatively more curved clavicle, it's very difficult to visualize all the three chords at time. So is it a limitation for this block, or is there any tricks to advise?
I think to answer your question, Tony, is there is never a yes for everything. There are always difficult times when you do this. But my advice to you is when you do these costoclavicular block is to get the arm abducted as far as is comfortable for the patient. Now, there are two things. It elevates the clavicle to a certain extent and allows you more space to place the transducer, because very soon you will find that the coracoid process comes in the way of your transducer as well as the needle insertion. So once you elevate it, it kind of takes it outward and upwards and gives you more space for transducer placement and needle placement. So whether you are able to see three chords in most cases, I think I would say in majority of individuals, you are able to delineate all the three chords in that nerve cluster. My advice to you is, if you're not familiar with the costoclavicular brachial plexus block, is to start off using nerve stimulation. This is a very good example of learning anatomy, physiology, everything together, because when you guide your needle and ensure that you're using dextrose 5% instead of normal saline, for the reasons for which you're very familiar with, when you advance the needle and you approach the lateral cord or say the posterior cord, you immediately get a response that is consistent with stimulating that particular cord of the brachial plexus. And with time, you become very familiar with which one of these elements is which anatomical structure or which nerve. After a while, you don't need the nerve stimulator as such. So yes, you can identify all three chords in majority, and in some they are so tightly packed that I often say, okay, this is not maybe a good case to do this. We can move on to another location. Because if you try and hydrodissect your way into the center of the cluster when they're very compact, I think the chances of needle nerve contact is proportionately increased, which may not be desirable. Okay.
May I just add that exactly the same argument that you now present for starting continuous nerve blocks, you should also do exactly the same with the catheters. In other words, start off with ultrasound and then put a nerve stimulator on the catheter until you get very familiar with that, and then you can later on drop the nerve stimulator. But you have to learn that first, and that's certainly my way of teaching these. I start with everything I have and then take the other stuff away as we become more familiar.
Yeah, I think what you say, Andre, is a words of wisdom, and I have great respect for that. But I think the audience would also appreciate that the ultrasound does not supplant the nerve stimulator. But when you marry them together, you have a winning combination, not only for clinical efficacy, but also for learning and teaching. If you have young doctors in your vicinity who are watching you doing it, or you're teaching them, I think using them in conjunction should be our way to go. We're not trying to prove to anybody that this is better than the other. But when used in conjunction, you have two different modalities that gives you two different information. One is giving you anatomical information. The other one is giving you physiological responses, anatomical responses that you become very familiar with time. Okay, thank you, Christine, for moderating this and getting hold of the questions that you did. I like to take this opportunity to thank you, George and Andre. You've been great teachers in this field. And today I was so excited for the last few days that we would all be three together to present. And I think we did a bloody good job. So if you are an audience listening, you will not find a session like this anywhere, I tell you. So if you have a friend who hasn't visited this webinar today, ask them to register. They will get a link which they can later on watch. And this will definitely help you in your clinical practice. Thank you again, both of you. You've been great champions, and keep on staying safe and well. Don't go away. You don't have to go away, but we have another session. So all of you, I like to take a short break, give you all a short break. Go and pick up your favorite beverage and be back in 15 minutes time from now. Thank you.
Thank you.
Hello. Welcome back. I hope you're refreshed and you're ready for more. And no more better than Professor Feigl to again start the proceedings for this second session. I've already introduced Professor Feigl to you. In this second lecture, Professor Feigl is going to discuss the functional anatomy of the sciatic nerve and its common anatomical variations.
So thank you again for the introduction, Manoj. Well, I talk about this sciatic nerve, and first of all, we just have to get again to a short repetition, which is not more than a minute. As you can see, if it's working. Oops, here we go. So get the sacral plexus, which is formed by the ventral rami again from L4 to S4 or S3, depending a little bit if you, for example, involve the pudendal nerve or not. If you include the pudendal nerve in the sacral plexus, you have to include the fourth sacral segment. If you exclude the pudendal nerve, which some textbooks do, you have to exclude the S4 segment. Anyway, we include it, and the pudendal nerve is, because of its connection and topography to the sciatic nerve, a very important nerve, which should be taken into consideration for different pain blocks and also regional anesthetic blocks. The sciatic nerve itself gets major contributions from L4 to S3, and as you know, divides into two nerves, which is the common peroneal or fibular nerve and the tibial nerve. Anyway, it's a very important thing that you take a look on the development of these the sciatic nerve, because the common peroneal or fibular nerve gets its major contribution from the more cranial segments as the tibial nerve. And this is a very important thing concerning also the variations of the sciatic nerve, especially in the exit area of the lesser pelvis area to the gluteal region. So where is the sciatic nerve exiting? It's exiting through the so-called area of the infrapiriformal foramen, which means you get the greater sciatic foramen, and then you have the piriformis muscle exiting to reach the trochanteric fossa. And underneath you have this infrapiriformal foramen, which is, well, quite a small foramen, but anyway, there are many structures running out, like, for example, the sciatic nerve, the inferior gluteal artery and nerve, also the internal pudendal artery and the pudendal nerve, and the posterior femoral cutaneous. So you see a lot of structures running through to go to the distal areas. If we make a drawing or took a look at the drawing, you see this foramen, which is absolutely filled up with structures over there, and not only nerve fibers, but also arteries and veins, which are then, for example, the vein draining into the lesser pelvis area. If you take now a dissection, where you can see the gluteal region and then make a windowing of the gluteus maximus muscle, you see the piriformis muscle and then the sciatic nerve, which is really a really thick nerve at that time already, and not, for example, separated, as you can see sometimes also in the ultrasound images. And you see just medial to it, there is the posterior femoral cutaneous, sometimes in a very close relationship to it, but over here, this is the nerve which is a little bit more located medially. So if we take now a second look on this foramen, you can see more medially the internal pudendal artery and then the nerve, which is even more medial to it. The pudendal nerve, which has to enter again the lesser pelvis area, but underneath the levator ani muscle. And is then entering also a small tunnel, which is called the Alcock's canal. The sciatic nerve itself passes underneath the great gluteus maximus, but is more superficial to the short pelvic muscle, which are also called the pelvic trochanteric muscle group. And this is very important because you really can see distinct the nerve itself, and also with its connection and topography to the other structures. So what about variations over there? As I already told you, you can see the so-called piriformis muscle syndrome, where the peroneal or common fibular nerve pierces the piriformis muscle, and therefore you have a separation by this muscle, which can continue down to the popliteal fossa area. So they're never really are that close to each other, but really run in two different canals distally. In the area of the gluteal region, you have always to think about the topography and the muscular structures which can be visible with ultrasound images. And at the level of the sciatic tubercle and also the so-called intertrochanteric crest, you have this muscular structure, which is the quadratus femoris muscle. And there you can see over here, if you make a cross section, you see this muscle as a very hyperechogene, muscle partially really hanging through and getting the sciatic nerve close to its surface. As you can see this on this cross section, you see over here, this is the femur and the sciatic tubercle with this distinct tendinous origin of the hamstring muscle group. And then the quadratus femoris passing, going laterally, and the sciatic nerve, which is covered by the gluteus maximus muscle. And you can see distinct also a very separated nerve part, which is also already the posterofemoral cutaneous nerve. So if we make another cross section, you see this hyperechogene muscular structure, which is really very, very useful as an anatomical landmark. If you start your search for example, the pudendal nerve or also for the sciatic nerve from distal going more proximal, you know that there are also other ways to identify the sciatic nerve, for example, proximal distal direction. So you see the quadratus femoris and again the sciatic nerve in this area. If we move now more proximal, you see we are now at the level of the obturator internus muscle, which is turning around the sciatic bone and then going to the trochanteric fossa. And you see the sciatic nerve itself is getting more medially already. If we go now to the area of the sciatic spine, you get over here the sciatic spine, and you see the sciatic sacrotuberal ligament, sacrospinal ligament, sorry, and over here the sciatic nerve again, but also, of course, be accompanied now with the inferior gluteal nerve, as you can see it over here, and also the inferior gluteal artery, and just medially to it, you will find over here, for example, the internal pudendal artery and the pudendal nerve. And if you move now on to the infrapiriformal foramen, you see that the piriformis muscle is coming from the ventral surface of the sacrum and running distally and laterally. And you see this area, this is now the infrapiriformal foramen quite easily. But let's take a short look a little bit closer, that you can see you are now really in the lesser pelvic area with all the different structures which are medially. And this is something which have to be taken into consideration, that you do not position your needle tip too deep, because then you're really in the area of the lesser pelvic area, and there are huge venous plexus over there, which can be damaged, and you have a lot of hemorrhage and bleedings over there. I already talked about the pudendal nerve, which is more medially, and just think about, okay, we get now the isolation of the sciatic nerve. If we can inject, for example, a higher volume of, let's say, 3, 4, 5 milliliter, does it really spread, for example, to the pudendal nerve? And the answer is unfortunately no. Sometimes it does, and sometimes, as you can see, it does not, because over here we made a singular injection of the pudendal nerve, which is with the latex, and it does not spread to the sciatic nerve itself. And we really put the question why. And again, it's like in the brachial plexus area, you get this septa, really a very dense connective tissue layer, which is separating or partially or sometimes separating the pudendal nerve and the internal pudendal artery from the sciatic nerve itself. So if you turn it now around and say, okay, I can inject at the area of the sciatic nerve and it's running medially, sometimes it does, sometimes unfortunately it does not. And therefore you have to do a separate and injection of both of these nerves. It's like a snipering, as you already have to do, for example, in the axillary fossa concerning the brachial plexus. Let's move on. This is now a posterior view of a lower limb area, gluteal region. You see the quadratus femoris in this area. Over here, this is the obturator internus with the gemelli. This is the piriformis, the infrapiriformis foramen, and the nerve running distally with the posterior femoral cutaneous nerve, close relationship to it. And take out now a little look on the topography of the nerve, which is very close to the sciatic tubercle. Regularly you found this 3/3 of the line in between the greater trochanter and the sciatic tubercle, and then it's used to be that it said, okay, in between the middle and the medial third, you find the sciatic nerve. Not that true, because it's really very close to the sciatic tubercle. So really take a look in this area. If we make now a cross section again with the quadratus femoris, it's quite familiar to you, because you can see the quadratus femoris again and the sciatic nerve just superficial to it with the posterior femoral cutaneous in this area. And now let's take a look, whereas the pudendal nerve is already in this Alcock's canal, which can be visible quite easily with the fascia of the obturator internus muscle. Okay, so what about now a cross-section and enlargement of the sciatic nerve? You can see much more space in between and already distinct the two nerve parts, which is medially the tibial nerve and the common peroneal nerve laterally. And over here, you can see already a small distinct fascial layer, which is separating now the posterior femoral cutaneous from the peroneal and the tibial part of the sciatic nerve itself. So we have somebody who described also this wonderful paraneural sheath. I know that's the term which some, for example, do not like to hear. But anyway, what about the paraneural sheath or any other term of it? Does it exist also at the level, for example, of the sciatic nerve? And I can really confirm that such a sheath or dense connective tissue layer, however you want to define it or name it, exists. And let's take a look on the dissection. For example, you have the gluteus maximus muscle. We elevate the gluteus maximus muscle. Over here you can see the hamstring muscles covered by the fascias. Then continue with elevating. Then again, we have over here the sciatic nerve running distally, still covered by this dense connective tissue layer. And then over here you can open this fascial layer, and the sciatic nerve, which is running distally, we think, okay, is this already the so-called paraneural sheath? No, it's not, because if we continue again, we can still have this connective tissue layer around, and then you can see you can open this really fascial tunnel, which is formed by a fascia which is in the pelvic area, well developed, and then going distally, and this is a tunnel where you can insert the tweezer and advance the tweezer until the popliteal fossa. So it remains in this tunnel, which is really surrounding the both of tibial and common fibular nerve in total. So what we are thinking about is where this so-called sheath is coming from, originating from. And we assume at this point that it's coming from the parietal pelvic fascia. So it might be continuation and forming like a tunnel, which is exiting and also converging distally and surrounding the sciatic nerve in this area. If we make a cross section, you also can see this this fibrous tunnel, which is not the epineurium, which you can see over here. It's really a huge space surrounding this area and surrounding the nerve. And again, you can dissect it in longitudinal sections, and you can also form it by a tweezer. But you can see over here, sometimes it's a more dense and sometimes it's a thinner layer, as you can see on this dissection. What other problems can you have? This is something which was a case report, but anyway, it should especially give you, well, an idea what might happen if you do not follow the guidelines, for example, intragluteal muscular injection. Well, you all know that the injections for COVID are performed regularly in the deltoid muscle anyway. There's still the so-called Hochstetter method to the middle gluteus medius muscle, which should be over here. And some do not respect these quadrants and perform the injection through the gluteus maximus muscle. And if they insert the needle too deep, for example, you might cause an ossification of the tendon of the piriformis, and also an ossification which is running parallel to the sciatic nerve. This would be the course of the sciatic nerve. And as you can see, this is like a tooth of a tiger, more or less. And this was caused by a wrong intramuscular injection, which is parallel to the sciatic nerve, and the peak was really staying in the sciatic nerve, causing pain. This is something which has to be taken into consideration sometimes. If we go now more distally, you find the popliteal fossa. And you find, of course, the borders of it, which is the biceps femoris laterally and proximally. The gastrocnemius lateralis is lateral distally, and medially, proximally, you find the semitendinosus and especially the semimembranosus muscle. And distomedial, you find the gastrocnemius muscle, the medial gastrocnemius muscle. So it's more or less like a rhombus, especially in the distal areas, very distinct and wonderful borders formed by the muscle. And the tibial nerve is really straight, running distally. In the popliteal fossa, it's the most superficial structure in this area, covered by the popliteal fascia itself. And the common peroneal fibular nerve is more or less covered by the biceps femoris tendon, a little bit underneath, and therefore get a cover up by this muscle. Running distally and passing the head of the fibula dorsally to turn around at the neck of the fibula, going ventrally and entering then the common or the fibular muscular compartment. So let's take a look on the dissections and also cross sections in this area, where you have this dense fascia, and underneath if we elevate the fascia, you have now this entire fat tissue compartment where when you inject, you really have this absorption in this area by the fat tissue. And even if you elevate the or remove the fat tissue, you find the tibial nerve first, and then you can see lateral and more a little bit at the border of the biceps femoris muscle, you find the common fibular nerve, which is running distally, as you can see it over here. Then you have some branches arriving, which are the sural branches, the lateral sural branches, and also communications to the sural nerve. If we remove or move the semimembranosus and tendinosus more medially, you find the tibial nerve really running straight down and be covered by the hamstring muscles in the more proximal area. Let's make a cross section now. You can see over here on this cross section the popliteal vessels, and also over here the sciatic nerve with this distinct already separation by the nerves. And let's take a look on the enlargement. As you can see, this is the common paraneural or fibular nerve, the tibial nerve, still being close together already in the popliteal fossa. Nevertheless, you find a small nerve down here, which is separated also by a small fascia because it's running down with a fat-filled fascial tunnel, which is the posterofemoral cutaneous. And if we take a look now on this paraneural sheath again in the popliteal fossa, this is something which is quite nice, because if you inject, for example, in between the two, you still find this perfect distribution spread underneath this sheath. As Manoj Karmakar already said to you, this is causing a very distinct proximal distal spread. And absolutely, if you're underneath this sheath, this will stay in this area. It cannot go to the fat tissue. It cannot go really para to this fascia. It stays underneath and gets a huge extension proximal distally. Even that if you inject, it might reach, for example, also the infragluteal region, because it's really previewable that the spread only can stay in this tunnel. And this is something what you have to keep in mind concerning all the different distributions. What else can be? If you follow or trace the sciatic nerve distally, as one major important thing, that you get also sometimes a very late separation of these nerves at level of the knee joint gap. So don't be afraid, and if you really move the probe distally, it might be that both of them, common peroneal, fibular, and also tibial nerve, are still very close together, very close together, very close together, and then finally the common fibular nerve turns laterally and run laterally to reach the head of the fibula. Okay, so I think that's from my point of view. One nerve still missing, posterofemoral cutaneous, which is also very distinct with its course. As you can see, it's still very close to the sciatic nerve in the gluteal region, and from the infragluteal region, it's separating very to remain subfascially, but is superficial to the biceps femoris. And this is something which is very important, because if you go distally, for example, as you can see it over here, you have the posterofemoral cutaneous underneath the fascia. The trunk of this nerve remains underneath and runs distally. You have the cluneum inferioris over here. And then if we open the fascia of the thigh, you can see the trunk of the nerve running underneath the fascia and just send some fibers, some branches through the fascia to the skin areas. And as you can see, this is the biceps femoris over here. You see the posterior femoral cutaneous, and then if we open and elevate, still the posterior femoral cutaneous, but, and this is an important thing, still separated from the sciatic nerve in this area. So if you really want to block them, you have to block them again separately. And this is something what you always, it's like a deja vu. We found it in the brachial plexus, we found it in the femoral nerve, we found it everywhere. You find these fascial tunnels and the separations by the fascial structures. Okay, so thank you again for your attention, and you can see it still motivating if you do it dissection, for example, 1,000 times, or performing blocks 1,000 times. It's still thrilling and it's still a challenge each day. Thank you very much.
Thank you, George. As they say, practice make perfect. That was a wonderful presentation, George. Look forward to the discussion that will follow. I think you give me great pleasure to now welcome Professor Miguel Ángel Reina. I've introduced him in the very outset, but now as a short introduction, I have a short mention. He is indeed a champion of microanatomy. What we'll know today is indeed his work, and it has really opened up new avenues in the area of regional anesthesia, pain medicine, etc. And no better than Miguel to talk to us about microanatomy of the sciatic nerve and its potential clinical implications. Miguel, the floor is yours.
Okay, there are now some problem with the camera from my face, but not by the my presentation. Okay, what are the different structures within the sciatic nerve and also all nerves? You can see a myelinated axon with its Schwann cells. An unmyelinated axon. Here, 10 unmyelinated axons surrounded by plasmatic membrane of Schwann cell. Always, we found package of unmyelinated axon, never unmyelinated axon alone. Here you can see the covering of nerve, endoneurium, perineurium, and epineurium. Sometimes the terminology is a problem. I will consider epineurium only the most external covering of nerve, and fat among fascicle as interfascicular tissue. In this picture, you can observe under transmission electron microscopy a myelinated axon surrounded by collagen fibers. These dots are the cross-section of collagen fibers. This is endoneurium, a permeable structure for local anesthetic. Now, the same sample studied under scanning electron microscopy. Endoneurium form tunnel for each axon. These tunnels avoid electrical field interference. Endoneurium is compact, is not soft. Perineurium is the edge of fascicles. The arrows show the perineurium formed by 8 to 14 concentric layers. Perineurium is formed by cells, perineurial cells. Perineurium is not distensible. Perineurium is the most important structure within the nerve because it governs the passage of molecules deposited outer the nerve toward the target, the axons. This is semi-permeable membrane. The onset time of anesthetic block depends on this barrier. It will be different in different nerves. This barrier is formed by a specialized plasmatic shantion as texantion and desmosomes, allowing plasmatic membrane tightly joined together between them. There are not intercellular spaces. A transcellular passage is only possible in the diffusion process. The pinocytosis vesicle process through the cell is another choice. Interfascicular tissue among fascicle is mainly fat, adipositis. It is soft, elastic, distensible, an excellent lipophilic reservoir. This tissue is found among the fascicles. Big and small vessels were within this tissue. Epineurium is the external cover of nerve formed by interlacing collagen fiber. It is permeable structure for local anesthetic. Here in blue, the epineurium. We found recently a cover outer and close to perineurium. This structure is like epineurium but surrounding each fascicle. Therefore, the perineurium is not in direct contact with adipositis. Adipositis are in contact with this new cover. This is a second protective cover in each fascicle. This new cover is permeable for local anesthetic. The barrier is only the perineurium. You can see perineurium in blue, and like epineurium, close outer perineurium. This cover is formed by collagen fiber like epineurium. In this diagram painted by Mary Brisson, you can analyze epineurium of sciatic nerve, epineurium of tibial nerve, and common peroneal nerve, and like epineurium surrounded each fascicle outer perineurium, including interfascicular connection between fascicles. We can see a sciatic nerve block under ultrasound. The needle tip is seen outer the nerve. This is the common peroneal nerve, and this is the tibial nerve, or is the sciatic nerve. After injecting, a donus sign was found surrounding the sciatic nerve at the tibial nerve border. Here, it was found a donus sign, a partial donus in A surrounded sciatic nerve at common peroneal border, and another two partial concentrically donus surrounded at the tibial in B and C. What's more, we found a donus seen as a partially concentrically donus surrounded sciatic nerve in A, B, and C. What will be the donus shapes image in our patients? There are a lot of possible choice. Yes, because sciatic nerve has a lot of concentrically fat compartments surrounded around of it one. Each one of these fat compartments is limited by collagen membranes, like epineurium of sciatic nerve, the circumneurals. The needle tip could be placed in this one or another fat compartment, and different donut shape may be developed. The same local anesthetic volume could be entrenched in one or another fat compartment with different spreading and logically with different outcomes. The innermost fat compartment, innermost donus, will perform a base block, lesser onset time, and longer duration. And we perform a block injection within an outermost fat compartment. A poor block will be reached with a longer onset time and shorter duration as a result. Could it be an intraneural injection within sciatic nerve? Macroscopically, sciatic nerve is a nerve but microscopically, sciatic nerve does not exist at that level. They actually are two different nerves. Each nerve has its own protective epineurium, but basically it is a terminological problem. In this case, local anesthetic volume was injected in the rear innermost fat compartment of the tibial nerve and common peroneal nerve. Conceptually, this one is not an intraneural injection. In this picture, we see several concentrical circumneurons, also named paraneurion or circumneurons. The origin of the circumneurons are the adventitia of the vessel. Then you follow the arrows. An epimysium of muscle is another source of paraneurion. Please follow the yellow arrows. This is the epimysium. This translucent membrane is epimysium of muscle. This aspect is similar to circumneural membranes. All nerves that we would like to perform an anesthetic blow are within fat compartment, immersed within fat. Fat always surrounds the nerves. There are not nerves without fat in close contact. Fat is the essential element for spreading of local anesthetic volume to occur, and the border of fat compartment is the circumneurium that limits the pathway where the local anesthetic volume spreads. The pathway where the anesthetic solution volume may spread appear among the adipocytes simulated in this marker in red. Adipocytes are not broken or crushed. Adipocytes are detached from the protein matrix that fixes adipocyte among them. The adipocyte tissue is soft and distensible. Here, the details of adipocytes are marked at more magnification. This is the real pathway of local anesthetic volume when we perform an anesthetic block, injecting near the nerve, or also in a fascial block. Fat is the most important element for spreading of a solution. All nerves and plexus considered for us in the regional anesthesia techniques are surrounded by fat. Fat is the key word. Macroscopically, sciatic nerve is a nerve, but microscopically are two nerves from its origin, tibial nerve and common peroneal nerves. Each one had most conglomerate fascicle at popliteal region than gluteal region. The fascicle number is greater at gluteal region than popliteal region, but the fascicular area is lesser than other one. As a sciatic nerve is formed by two nerves, the tissue outer this nerve is actually like first and innermost fat compartment limited by the innermost circumneural. For this reason, it's possible to find septae within sciatic nerve. These septae are extended membrane with origin in this circumneural membrane and vessel within sciatic nerve between tibial and common peroneal nerves. All these new concepts were obtained from microscopic view. This circumneural will be the classic epineuron of sciatic nerve from a macroscopic view. You can check the different septae within sciatic nerve in light green and its epineuron in dark green. Using another terminology, the dark green line will be the innermost circumneuron of tibial and common peroneal nerve, but both descriptions are right. In a standard anesthetic block, the local anesthetic volume is injected outer the nerve. outer the epineurium of sciatic nerve. The volume spread in all directions. The approach within sciatic nerve, but outer tibial and common peroneal nerve at popliteal region, could not be an intraneural injection from a microscopic view, although it might look like an intraneural injection from a macroscopic view. The size and shapes of fascicle and the needle's orifice until now have not been considered, and these aspects are certainly relevant when we are considering an intraneural injection. Here, intraneural but extrafascicular injection appear in blue. Local anesthetic distribute exclusively around outer fascicles. This is a simulated extrafascicular injection. The vessel may be broken, originating an extrafascicular intraneural hematoma, fibrosis, and in the future probably develops dysesthesias. This type of lesion is unpredictable. The possibility of intrafascicular injection is real, but remember, fascical tissue has little distensible properties. Endoneurium is more resistant and harder than fat located in extrafascicular tissue. Here you can see an intraneural intrafascicular injection. You see fascicle and vessel, but it is important you check the diameters of needles and diameters of fascicles. A catheter may be unintentionally inserted within sciatic nerve, but where? Actually, in this picture, this catheter was not intraneurally inserted. Truly, from microscopic view, this catheter was placed within the innermost fat compartment located between tibial nerve and common peroneal nerve, but not intraneurally. The concept of an intraneural injector remained unchallenged until now. There are two possible ways on the intraneural injection: intrafascicular or extrafascicular spreading may occur. Such concept has been supported by experimental studies after injecting particulate marker, known as Indian ink. These concepts were generally accepted. However, our findings were significantly different when another marker was used for us. This is the traditional marker, Indian ink, used in the most studies. But what was the problem after to use this marker? It is not possible to identify singular particles of Indian ink, which are always seen as black spots formed by particles clamping together, possibly by electrostatic forces. Here, all joined particles at high magnification, such as 30,000 times. We developed a new marker and performed deliberate intraneural injection to evaluate the possibly intrafascicular and or extrafascicular injection. This marker was human blue heparinized with high doses heparin diluted around 15% hematocrit. Our surprise in human sample was high in our lab when we found that it was very difficult to achieve a spreading of a solution inside the fascicle after a deliberate intraneural injection, checking with swelling under ultrasound. We performed the intraneural injection in poor condition. 20 milliliters injected within sciatic nerve, and logically high pressure were reached. Most of the blood injected was found between fascicles, but almost always outside the fascicles. The marker had a spreading inside and outside sciatic nerve, within tibial nerve, but always outer fascicles. The fascicles were always clean. At more magnification, you can observe all fascicle clean, free marker. As you check, marker is outer the fascicle and nothing inside fascicles. After performing a deliberate intraneural injection, there was only marker outside fascicle and most fascicles were marker-free. You can see how the injected intraneural marker was retained by epineurium inside the nerve and how marker does not leak outside the nerve. The same image at more magnification, you can see epineurium and retained marker. Here we see how the marker spread between fascicle but does not pass across perineurium. After a deliberated intraneural injection, epimission also retains the marker, avoiding the spreading through muscle. Here there are not adiposities among fascicles, and here there was not intraneural spreading of solution. In this case, the spreading occurs only outside the nerve. All fascicles are clean and agglutinated. Fat is the key for intraneural spreading, and it is important to remember that not all nerves are seen, not all nerves, trunk, or cord, have adipocyte among fascicles. An important finding was to observe the marker between the layers of perineurium, which produce widening of perineurium that from an ultrasound view can be misinterpreted as fascicle swelling. But inside fascicle were clean. There was no marker between axons. There are also perineurium septae and marker is spreading through them. It can be misinterpreted as intrafascicular injection, but axons are clean on the picture. The increasing diameter of this fascicle is caused by intraperineurium widening, but not by intrafascicular spreading. The use of Indian ink would not allow the examiner to appreciate such details, and this finding could be misinterpreted as intrafascicular spreading. At more magnification, you can see the same, but in details. The marker spread through the perineurium layers. Tibial nerve inside sciatic nerve may have 35-40 fascicles, but in general, only one fascicle of them may be affected. Yellow arrow, only this fascicle, not the rest. At more magnification, after using a new marker, you will see that this is a pseudo intrafascicular spreading. Actually, it is not an intrafascicular injection. Instead, there is intraperineurium spreading through the perineurium septae. This is the spreading through the perineurium layer. This is the septum of perineurium and spreading through this septum. The same image at more magnification, showing details of spreading through the perineurium layers. At more magnification, a dilation at the end of perineurium septum thus can be misinterpreted with an intrafascicular injection. Overall, when another researchers had used Indian ink as marker, overall in the past. Now the question is, why is it so difficult to produce an intrafascicular spreading? Because the fascicular tissue was underestimatedly taken for soft tissue, and instead the axon and endoneurium are rigid, hard, and resistant tissue which prevent the passage of the substances across fascicles. The property of the endoneurius hold the key to understand such new concepts. Vulnerability of the nerve was another topic. This mathematical analysis allows to better understand to the different risks of nerves subjected to the different anesthetic techniques. After superimposing the microscopic full cross-section of nerve and the needle orifice image, we scan vertically and horizontally all possibilities to identify the needle orifice at different percentage of occupancy with fascicular tissue. We developed a software to acquire this data, advancing the imaging of the needle orifice over the cross-section of full nerves, allowed us to make accurate calculation of the risk of making an intrafascicular injection. Now, this is the software, and barrier in vertically and horizontally region of the same image. And now this is the zero, zero full occupation. But now 2, 8, 16. Okay. We consider that this risk could be high, over 80% occupancy of the needle orifice with fascicular tissue, blue places within the nerve. To aid the interpretation of this diagram, with assign color to each percentage value. And dark blue color is a full occupation and a high risk. There is a color bar with the correlation of occupancy percentage of each image. This allows to quickly identify the most sensitive places to the risk of injury by intrafascicular injection in a nerve. The blue mark the highest risk of intrafascicular injection within the nerve. This risk may be modified after using different needle diameters or beveled angles. Approach in different angle is another choice affecting the risk of intrafascicular injection. You can check the picture after using 15° or 30° on the needle bevel, as well as an approach at 45 or 90°. This study was performed over sciatic nerve at subgluteal region, and the blue dart is varied in different conditions. And the same method were also applied to sciatic nerve at popliteal region. The blue color marked the risk places in different conditions. So, unfortunately, we have reached the end, and it was a pleasure for me to share with you all our experience in our lab, and I hope that our result may be useful for you in the future and in their hospital. If you want, you can contact me through my email address. Thank you so much. Muchas gracias from Madrid.
Thank you, Miguel, for the wonderful presentation. As always, you're a champion of microanatomy. Every time I learn from you, today you have introduced a new concept, and I hope to sit back on a Sunday and try and figure out some of what you have just instilled in our thoughts. Thank you again. So, ladies and gentlemen, after these two wonderful presentations by Professor Feigl and Professor Reina, I will try and make this clinical connection between functional anatomy, microanatomy and then into our practice of for regional anesthesia. Now, while I am here, let me set up my pointer. Okay, here we go. We have a laser pointer. Now, I have no conflict of interest. For clarity, ladies and gentlemen, I am happy to share some unpublished data from some of our recently completed studies, because without that, I can't really make a lot of sense of what I'm trying to say. Also, if many of you are interested in what I'm going to say today, most of this detail is available in this recent educational publication in regional anesthesia and pain medicine by our group, including Professor Rayner. So you can download this article and read most of it. Now, before I begin, I would like to have a disclaimer in that whatever I say and whatever I show you about the various block techniques, it only applies to the sciatic nerve at the popliteal fossa, number one. Two is, when we think about the sciatic nerve, and as Georg has alluded to before, it is described as one nerve, but actually there are two nerves that are compactly organized together within a connective tissue layers to form the sciatic nerve. So it's often described that the sciatic nerve bifurcates at the popliteal fossa. That is a wrong concept. If there are two nerves, they can only diverge from each other. So I'm going to use the term divergence, not bifurcation. You know, a branch of a tree can bifurcate into two, but if it were two branches together and they were separating, they can only diverge from each other. So it may seem pedantic, but I think that makes the whole sense of what we are trying to convey through this presentation. So my objective is to briefly review the technique of subparaneural popliteal sciatic nerve block based on the anatomical and microanatomical information that we have, and then discuss with you some of the techniques that are currently described in the literature. Now, while they are techniques that improve clinical outcomes of these blocks, but there are limitations of these, and I'm going to highlight some of the limitations of these subparaneural injections. List, you go home, or you switch off your computer today and you think, I have learned about the holy grail of sciatic nerve block. No, that's not what I'm here for. I want to prove to you that the subparaneural injection is desirable, but we still don't know about popliteal sciatic nerve block, and we are no better than what we were before we started using ultrasound. Now you may say, what are you saying? Actually, today we use ultrasound. We can identify nerves, big, small, medium, whatever, in different areas of the body, and we inject local anesthetic in the perineural area. And in some cases, like the sciatic nerve, we have identifiable compartments into which we can inject to improve the outcomes. But the question is, are they really better than what we used to do before? Okay, I will try and highlight that and discuss some of the potential reasons why there is still a limitation in the sciatic nerve block. Is it just a poor understanding of our anatomy? Anatomy that we have ignored, anatomy that was described more than 100 years ago, that we have never slowly and conveniently forgotten along the way, and developed techniques that we are propagating today, but without proper due care of the anatomy that was already described. And as Professor Feigl also mentioned, that many of the things have been described more than a century ago. I will highlight to you with clinical evidence as to how this is important. And then we talk about how we can improve the anesthetic efficacy. Most of the studies in the literature with subparaneural sciatic nerve blocks are often as an analgesic technique. They would do the block, do the assessment, and then put the patient to sleep. Now, many clinical practices or surgical practices demand that. But if you are are one like me who wants to use it for surgical anesthesia, you will unfortunately be very, very disappointed. And if you haven't used it, or you have used it, you may have found it very disappointing sometimes to find that your subparaneural sciatic nerve blocks are no different than what you used to do with just ultrasound guidance or even with nerve stimulation. Now, these are a lot of philosophical words, but I tell you, ladies and gentlemen, this is my goal today. So sciatic nerve block is very frequently used for anesthesia and analgesia. And as I alluded to, it's very frequently used for analgesia in many practices. And with the use of ultrasound guidance, there has been significant improvement in our understanding of anatomy, particularly with respect to the paraneural sheath or the circumneural sheath, as we discussed with the brachial plexus. The circumneural sheath has been described, has been demonstrated to be an integral part of the nerve. As we discussed before, it has often been referred to as the gliding apparatus or even the mesoneurium of the nerve. It's outside the epineurium. So macroscopically and microscopically, it is different from the epineurium. Also, when you inject local anesthetic outside this connective tissue sheath, as opposed to inside this sheath, and if we, for this discussion, use the term extrafascial and subfascial, makes it simpler, okay? I don't have to repeatedly say circumneural sheath, etc. So if you inject the drug extrafascial as opposed to subfascial, they produce different sonographic appearances. More importantly, when you do extrafascial injections, it remains localized in the area that you inject. It does not spread in a longitudinal or circumferential direction over many centimeters along the length of the sciatic nerve, as you see when you inject deep to this circumneural sheath. Also, more importantly, when you inject into the subfascially, it is indeed produces a halo around the nerve, as you can see here. This circumneural sheath can be defined as a separate connective tissue, which is separate from the epineurium or the outer layer of the nerve. And this can produce clinical efficacy differences. As you can see in this demonstration by Dr. Anderson in this cadaver, the subparaneural spread of the dye does not reach the inside of the epineurium. So it is indeed an extraneural injection, given that the epineurium of the nerve is the outer skin of the nerve. As I showed you before, this is a collagenous structure, very elastic, it is transparent, and it tends to hold the local anesthetic or an injectate deep to it, but if you inject enough of the volume, it will eventually burst and dissipate to the surrounding paraneural space. With high-definition ultrasound during paraneural sciatic nerve injections, we have demonstrated that the circumneural sheath can be defined as a separate connective tissue layer, which is external to the epineurium of the nerve or the outer skin of the nerve, and is very distinct from the epimysium of the muscles. Now, this is posterior, this is anterior, so this is your biceps femoris muscle, and this is probably the adductor magnus muscle in the thigh. The circumneural sheath indeed circumneurally surrounds the nerve, and it is outside the epineurium. And when you inject local anesthetic, you can see it will contain it. However, when you look at with ultrasound, although you can see the perineural intermuscular tunnel, now I'm introducing what Dr. Cornish described as a rigid tunnel. You have a intermuscular tunnel through which the sciatic nerve passes from the pelvis onto the popliteal fossa. The muscle name changes, but the tunnel remains the same. And you can see that even with high definition ultrasound, it's difficult to define this structure before any injection. But I like you to note that the morphology of the sciatic nerve changes significantly. While it is a very flat nerve in the upper parts of the gluteal region and the upper parts of the thigh, it takes on a more rounded appearance and a more bilobular appearance, if that's the right word, as you approach the popliteal area. Again, remember, this is actually two nerves that are indeed opposed together by connective tissue layers. There are also many vessels in the perineural space, including very close to the sciatic nerve. This is often described as the sciatic artery that provides the nutrition to this nerve. As you can see here in the post-injection, subparaneural injection of on the sciatic area, you can see the paraneural sheath now pops up. You can see that it now creates an appearance where the common peroneal nerve is to your left. The tibial nerve is usually larger. So you can see the tibial nerve here. There are circumferential spread of local anesthetic around the tibial nerve and the common peroneal nerve. And as you go up the thigh, it becomes more non-circumferential, but still spread over many centimeters from the popliteal fossa to the upper thigh. So now this creates what most people would have understanding. That means it's like a 1, 2, 1, and it divides into 2, or it bifurcates into 2. So if for simplicity we say that this is a 1-2 model, okay? So it's a 1-2 model whereby the sciatic nerve divides into 2. You can see here that the sciatic nerve is now 2 components, and the paraneural sheath also dissects, is also separates into 2 and individually surrounds the common peroneal and tibial nerve. Now, this is the common understanding today, and based on which we perform most of the injections. So therefore, the anatomy of the sciatic nerve is indeed more complex than what the literature suggests. What am I saying? Now, the concept of epineurium, perineurium, endoneurium is right when you talk about any nerve. But when you look at the sciatic nerve, as it traverses its path from the pelvis on the way down to the popliteal fossa, it actually travels in this intramuscular tunnel, which is the paraneural tunnel that many investigators have described. So if we take this entirety, if we go from outside in, you can see that these are the muscles that form the tunnel, and they all have the epimysial layer. So this is the epimysium of the muscle. And then deep to that is the sciatic nerve. Each sciatic nerve, or each nerve within the sciatic nerve has its own epineurium. It has its own perineurium and the endoneurium of the nerve fibers or the axons that Dr. Reina has very eloquently demonstrated in his presentation. The circumneural sheath or the paraneural sheath is now surrounding the 2 nerves or the sciatic nerve, and there is fat in the fatty matrix that's interposed between the 2. So you have 2 compartments. Now you have a subepimysial compartment where you perform the extrafascial injections, and a subparaneural or a subcircumneural compartment, which is the subfascial injections are performed. So you now have 2 compartments into which you would inject your local anesthetic. So obviously, needless to say, the subparaneural compartment or the subcircumneural compartment was described as the sweet spot of the nerve by Dr. Boezaart many, many years ago. And indeed, many authors have also described it as the new destination for sciatic nerve block. In fact, there was so much excitement about this that even yours truly often thought maybe this is the holy grail of the sciatic nerve block. Those of you who have performed sciatic nerve block for surgical anesthesia and have been disappointed, like me, would have thought that maybe this is the holy grail which would make us possible to perform sciatic nerve block like general anesthesia. How disappointed we are today. But nevertheless, along the way, Dr. Messer and Dr. Gebhardt from Miami in Florida did this study with 3-dimensional ultrasound, although it was manually performed. You can see here they performed a needle on the anterior aspect with the patient lying. I think this is the posterior aspect of the nerve, which is tibial and common peroneal. They placed the needle subfascially and they performed the injection extrafascially. What they showed is that a subfascial injection produces extensive spread along the nerve, whereas a extrafascial injection remains localized. And this is the basis why, because you have a subfascial injection, it contains the volume, and therefore you get much more extensive spread. And this is probably the reason why subparaneural injections produce better outcomes after sciatic nerve block. And what are these better outcomes as demonstrated by these investigators? It produces faster onset of sensory blockade. It produces a higher quality. That means to achieve a given score, if you may. So it produces denser blocks. And more importantly, and disappointingly, it produces very long blocks. Sometimes these blocks last up to 32 hours. Now, you would consider a fast onset of the block as a desirable effect of the subparaneural injection. Maybe a denser block in the very outset would be desirable. But a block that lasts for 32 hours in many of my cases, it is not desirable. But because it is a concern to the surgeon, it is concern to you, and to a patient, it is very, very uncomforting. It's very, very unpleasant to have a dead leg for 32 hours, especially if you come for a simple foot operation. But more importantly, these subparaneural injections are less likely to fail. Okay, so now when we do these blocks, and as I mentioned, what I'm going to show you and demonstrate to you only pertains to the sciatic nerve at the popliteal fossa. Most of the published literature describes it at the divergence of the sciatic nerve, where they diverge into two, and there are numerous publications. Above the divergence, there's very limited data, and I will show you some of our work in respect to this with the subparaneural injection below the divergence. And I will try and justify to you why one is desirable and then the other, and so on and so forth, based on some evidence. Now, when you look at the point of divergence, this is the common site where everybody touts is a point of sweet spot for sciatic nerve block, particularly subparaneural sciatic nerve block. Why? Because it is difficult to delineate the paraneural sheath above this site, as I have already demonstrated to you, that it only becomes better visualized where it takes this bilobular appearance, where the sciatic nerve is closer to the popliteal fossa. And at this site, the paraneural sheath encompasses both the tibial and the common peroneal nerve. So at the point where it diverges, the connective tissue sheath is now loosely attached around this nerve. So if you place a needle in the groove between these two, then you are subparaneural, but you're still outside the internal architecture of the common peroneal or the tibial nerve. And when you inject, this tube now contains the local anesthetic and provides you all the goodies that an injection like so does, like it spreads extensively. It not only spreads up and down the nerve, but also around the nerve. And because you're placing the needle in between the two nerves, it also facilitates atraumatic needle placement. And a single injection gets spread quite extensively. Now, as I mentioned, the sciatic nerve morphology changes as you come from the upper subgluteal area to the popliteal fossa. You can see here, even before it starts to diverge, you can see that the two nerves are very difficult to define, and so much so that the paraneural sheath is rarely discoverable in this case or delineatable. You can see here, this is actually the epimysium of the two muscles, that posterior and the anterior muscle. However, as the appearance changes, you will see the sciatic nerve closer to the popliteal fossa in this high-frequency linear scan. You will see they start to diverge, and with it, the connective tissue start to separate, and they also become more clearly definable. You can also see that this is laterally is your left is your common peroneal, and for this discussion, this will be the reference. To your left will be common peroneal, to your right will be the tibial nerve. And if you place a needle in between the two, that's how this technique is described, you can then get spread not only to the two nerves distal to its divergence, but also along the proximal part. Now, this is a cadaveric dissection that I again performed with Professor Sala Blanche in Barcelona. You can see we place the needle. This is just to illustrate to you. This was done with ultrasound guidance in an intact leg in a cadaver. But after we dissected the sciatic nerve out, this is just to illustrate where the needle was placed. And you can see 10 mils of a colored dye with methylene blue, not only spread along the top of the nerve cranially, but also caudally to encompass not only the tibial nerve, but also the common peroneal and its branches, maybe the sural branch or its peroneal communicating branch. So you see here, but however, also note that this is not a circumferential spread. It spreads along one side of the nerve as opposed to completely around the nerve. But when you take a closer look intact, it appears to you that it really bots the nerve, not only the common peroneal, but also the tibial, including the main trunk. And therefore, you should, in principle, get a very rapid onset of block, a good onset of complete surgical anesthesia. But is that really true? We will come to that. So when you put a needle at the divergence, you not only see peeling away of the paraneural sheath, you also see separation of the tibial and the common peroneal nerve. There's expansion of the paraneural sheath or the circumneural sheath, but there is no expansion in the nerve per se. And there will be extensive proximal and distal spread, so much so that different halos have been described. So if you look at the main trunk, you see a single hypoechoic or anechoic halo around the sciatic nerve, which distally will appear to you as a twin halo because it follows the common peroneal and tibial nerve. So for this discussion, again, when you see 0, that means this is the point of injection. Any -1 means this is proximal cranially to that site, and anything plus is caudal to that site. So if you see here, this is 0. This is about the point of placement of the needle. We place the needle tip here between the common peroneal and the tibial nerve. We inject 2 to 3 cc's of saline. You can see caudally there is a formation of halo around the tibial nerve and some halo around the common peroneal nerve. It has also spread proximally to the main trunk, and it surrounds mostly the posterior aspect because the patient is prone. This is posterior, this is anterior, along the posterior aspect of the sciatic nerve. This is what we describe as a trihalo. Now, you not only see 2 halo, you can see now this is the sural nerve, and this is the common peroneal nerve as they're separating. You can see this creates this trihalo. So the anatomy is now more complex. You can see here, the common peroneal, the circumneural sheath actually follows the individual nerves. And why not? Because this is an integral part of the nerve, and it does so. So much so, if you follow the injectate distally, you will not only see a trihalo, as in this case, you can see the tibial nerve halo, you can see the common peroneal nerve halo. This is the lateral sural cutaneous nerve halo. If you follow in some individuals, you can also see the peroneal communicating branch halo here. This is the lateral sural cutaneous. This is the common peroneal. So you can see a quad halo. So a halo around the nerve distally usually indicates a subparaneural injection. Now, when you perform an injectate of about 25 mils, as in our case of 0.5% ropivacaine or levobupivacaine, this is 0. So this is the point of injection. You can see distension of the circumneural sheath with anechoic local anesthetic, separation of the common peroneal and tibial nerve. It also spreads distally to produce the halo and separation of these 2 nerves. But I like you also see that it spreads quite extensively proximally. More importantly, pay attention to the internal architecture of the nerve. Can you see that there is local anesthetic within the sciatic nerve here? And within the sciatic nerve on what appears to be a kind of a septum between the 2, you now can see a halo around the common peroneal nerve. You can see a halo, at least a semi-halo around the tibial nerve with something intervening. And more proximally, this is about the infragluteal area, just below the gluteus maximus muscle. You can see a septum actually appears between the halo of the tibial and the common peroneal nerve. These blocks are usually very rapid in onset, and they produce very quick onset of sensory motor blockade. So what does a subparaneural popliteal sciatic nerve do when you perform it at the point of divergence when compared to a subepimysial injection? It produces faster onset of block. It produces higher quality, that means denser blocks. The blocks are also long duration, sometimes, as I mentioned, up to 32 hours. These blocks are less likely to fail. Now, why do they produce such long durations? Today, there are no pharmacokinetic data with subparaneural injections. But my gut feeling is you are depositing a mass of drug into the subparaneural, subcircumneural compartment, which is relatively avascular. So I believe the washout of these drugs or the elimination of these drugs are slow, and thereby the washout of the local anesthetic from the vicinity of the nerve is slow and thereby produces very long duration of block. And as I said, sometimes not desirable. So if this were the case and it was all good, then what are the limitations? When you look at an ability of subparaneural injection at the point of divergence and its ability to produce complete sensory motor blockade in 30 minutes, it is rather disappointing. Even these investigators who evaluated them report somewhere between 60 to 92%. But it also depends on the drug you use. If you're using drugs like mepivacaine, you're using drugs like lidocaine, then obviously you get a much higher percentage. Now, not much attention has been paid to the choice of drug for these subparaneural blocks. Hopefully, I will convince you that a shorter acting drug may be more desirable. First of all, we said that the prolonged dense motor block is not desirable. Now, we often think that lidocaine produces short duration of block. You try it using it in a sciatic nerve block, you'll be pleasantly surprised. You get 8 to 12 hours or even longer sometimes of dense motor block after lidocaine, indicating that maybe we should pay some attention to the choice of the drug. So the favored site at the bifurcation is really not ideal. And today there is a paucity of data comparing the different techniques at the divergence, above the divergence, and below the divergence. So with this, we set out to try and evaluate some of this story that really hasn't been told. Another limitation of this hydrodissection at the point of divergence is that occasionally you will find that there's an asymmetrical distribution of the injectate below the divergence. So now if you were to inject it, it will mostly produce probably a very rapid onset of tibial nerve block and a much more slow or a failed common peroneal nerve distribution. So what about above the divergence? We really completed a pilot study, and I like to show you some of the disappointing results. This is the sciatic nerve above the divergence, so you can't really see the circumneural sheath, but I believe that, and as shown in histological images, you can see that there are redundant circumneural sheath on the lateral side, posteriorly, as well as on the edges of the nerve. So our goal was to try and insert a needle to the lateral aspect of the common peroneal nerve, hydrodissect it, and then place some saline, and then confirm its subparaneural by the various signs that I showed you before, the halos, etc. So we used both nerve stimulation and ultrasound guidance. The needle was introduced in plane for the injection. So you can see here, the needle is coming from the lateral end towards the sciatic nerve. This is at the mid-thigh. You can see it's above the divergence, above the popliteal fossa. You can't see the popliteal artery here. You can see this is the epimysium. As you advance and you enter this space, you can see the subepimysial space. You can see that the nerve is now being pushed away. But the moment you breach the, you slowly advance your needle millimeter by millimeter, you will see that the paraneural sheath will slowly pop out. You can see here the separation of the paraneural sheath, and we try and keep it lateral to it so that you don't inadvertently insert it into the nerve. But I have to say, in this study, we found a very high incidence of paresthesia, about 65% reported by these patients. You can see here the saline has hydrodistended the space, and we then inject the local anesthetic at a single site. This is to show you in a video what happens. You can see here the saline. In fact, the needle is touching the lateral aspect of the common peroneal nerve. You can see as you inject, you can see there is the paraneural sheath pops out, and you can see separation and distension of this space. And now you can see the attempted circumneural spread of the drug deep to the paraneural sheath once you start injecting your local anesthetic. So much so that you not only see a good spread around the nerve, but it's not always totally circumferential. You often cover about 60 to 80% of the nerve. This may be related to some of the muscular branches that emerge from either side of the nerve, preventing it. You also get a fascial click when you go through the circumneural sheath. The local anesthetic often spreads about 60 to 80% of it. Great extensive craniocaudal spread of the local anesthetic deep to the paraneural sheath you can see here. Even with three-dimensional ultrasound, we have demonstrated that the local anesthetic not only spreads in the axial plane, but it also spreads in the longitudinal plane, cranially and caudally. And also in the coronal plane, you can see that there's a lot of local anesthetic spread to the right and left of the nerve. And you can see here, I like you to focus in between the two nerves. You can see a hypoechoic area. This may be related to the nerve that finds its way into the center of the nerve, as I showed you before. This is better seen in this 3D volume that we have rendered. You can see here the tibial nerve and your common peroneal nerve and the paraneural sheath that surrounds it with the local anesthetic deep to it, and some of the local anesthetic that has actually found its way in between the two nerves. On a view from the lateral side, you can see there is local anesthetic both to the right and left, and in between the nerve, you can see this. In fact, the local anesthetic spreads about 14 centimeters up and down the nerve. You would think this would produce what you really desire for, a real general anesthetic type of sciatic nerve block. The spread cranially is better than caudally, and it covers about 80% of the nerve. If you divide the sciatic nerve into 12 sectors, then 8 sectors with the median distribution. And if you look at the duration, as I mentioned to you, it's a mean of about 17, but the range you can see here in one patient, we had 32 hours. Also, this is a radar plot to show you the distribution of the spread of local anesthetic along the sciatic nerve. So if you imagine this is, to the left is your common peroneal nerve, and to the right is the tibial nerve, and this is looking at the halo of local anesthetic around the sciatic nerve just above the divergence. You will see that majority of the local anesthetic is actually spreading between sector 3 and sector 9. And this is where the common peroneal nerve is located. Although it has spread extensively along this route, but it has also spread extensively proximally and distally, so much so that with 25 mils, we've had about 14 centimeters of spread, a very rapid onset of sensory block. You can see sensory score from 0 to 100 on your y-axis, and this is 30 minutes at assessment time. You can see, even if we looked at the individual nerves of the tibial, common peroneals, or the superficial peroneal, deep peroneal, and the sural nerve, you can see the smaller nerves get affected first, followed by the larger tibial nerve. So the tibial nerve is more resistant to local anesthetic. But when we look more critically at the number of patients who had complete sensory is the black area, black bar here, complete motor is the red area here. You can see that only 20% of this cohort of 15 patients had complete sensory motor blockade at 30 minutes, and only 40% had at 30 minutes. So I think this really was very good for analgesia, and it produced undesirable motor blockade in some for up to 32 hours. But really for surgical anesthesia, at 30 minutes, it was very disappointing. Now, how does this compare with data that has already been published? This is data published with ultrasound-guided popliteal site in 2012 by German, and the group used 25 mils of 0.75% ropivacaine. In fact, a lot more than what we have used. But look at their incidence of complete sensory block and complete motor block on your left. You see that it's only about 10 to 15% of these patients actually develop complete sensory motor blockade despite circumferential spread was achieved. This is another good work by Didier Moreau and his colleagues, Dr. Choquet and Capdeville from Montpellier. They, in fact, found that at 30 minutes, only about 50% of them had. And when they woke up from the general anesthetic in PACU and they were tested, it was still only about 83% of their cohort of patients, despite a really good dose of ropivacaine that was used. So, ladies and gentlemen, subparaneural popliteal sciatic nerve block at the divergence or above the divergence doesn't seem to be the holy grail of sciatic nerve block that you have been wishing it would be. So it really brings out more questions than answers. So what is the ideal site for injection other than the divergence? Is it necessary to have a circumferential spread above the divergence or below the divergence? The choice of local anesthetic, the more I present you this data, you are now beginning to think maybe we should start to use only lidocaine as a drug, because this would now give you a pharmacokinetic or a pharmacodynamic advantage to produce a bang block. Unfortunately, it produces a high incidence of paresthesia, 65%, but fortunately, when they followed up to about a month, about a week and to a month, they don't have long-term consequences. So this is another study comparing a single versus double injection above the divergence. So this is about 3 to 4 centimeters above the divergence. We again identified the divergence and injected some saline to locate the sciatic nerve and the paraneural sheath, and then perform the injection above the divergence through a separate needle insertion. And in the single group, it was inserted either above or below, and 25 mils of ropivacaine 0.5% was injected. In the group that had 2 injections, they had both anterior and posterior the sciatic nerve, and the dose was divided into 2. When you look at the single injection group, you can see here, this is the point of injection at 0, and you see distal to it, there's extensive spread along both the common peroneal and tibial nerve. In fact, it covers almost 80 to 90% of the nerve above the bifurcation, and including up to the infragluteal area. This is a 2 injection technique. You can see one below and one above. We try and achieve circumferential spread as much as possible. Again, the spread was quite extensive up and down the nerve and around the nerve. But when you look at the sensory motor blockade, the double injection certainly won. So you need a even with the subparaneural or circumneural injection, subparaneural injection, a 2 injection is circumferential injection is desirable, and then a non-circumferential with 1 injection in terms of sensory block. The overall motor block at 30 minutes or 40 minutes was also better. But when you look at the sensory onset time, which was our primary outcome variable, the 2 injection group was much faster in onset, and there were no differences in the motor block. But again, when you look at the incidence of complete sensory motor blockade, if you're going to do surgical anesthesia at 30 minutes, even 2 injections with a circumferential spread above the divergence only gives you about 35% on an average complete sensory motor blockade. Now, that's not really a block that you can say is very consistent. It's many repeatable, so that you can use it for surgical anesthesia on a day-to-day basis. If you're prepared to wait for 50 minutes, even with such an extensive spread, you will only achieve about 70 to 80% by about 50 minutes. And I think none of us have a surgeon that is so accommodating or even so patient. Even if you had your procedure room, this would be a very undesirable wait of time. So let's look at below the divergence. So it begged the question whether an injection below would be better than 2 injections above. And in the past, before ultrasound, or even with ultrasound, injecting the tibial nerve and common peroneal nerve separately or on its own was quite common, because this not only allowed you to block the nerves that are much smaller, and therefore you had rapid onset of sensory motor blockade. So therefore we divided them, randomized them, observer blinded, with levobupivacaine 30 ml, 15 and 15 each, above and below the divergence. Above, I showed you how you do it. And below the divergence, also the same. You hydrodissect the tibial and common peroneal nerve with the 2 halos. You initially place your needle in the tibial halo. You inject 15 mils. And you can see here there's gradual distension of the tibial compartment. And then you put the needle in the common peroneal halo and you inject another 15 mils. Now you get nice distension of the common peroneal side. This is the spread of injectate after the twin injections below the divergence. You can see here this is 0. So this is above and this is below. You can see below there is extensive spread with a very well-defined septum-like structure in the middle. And as you go more proximally, you can see now the local anesthetic is trying to hydrodissect its way between the two nerves, separating the nerve into a tibial component and a common peroneal component. And again, even more proximally towards the infragluteal area, you can see separation of the two nerves. When you see such separation, there are two questions that came to my mind. Is it an intraneural injection? Certainly not, because we've done a subparaneural injection. Again, why is this two nerves separating out? This is the next question. I will come to that in a short while. So you can see here that the two injections below were outcome-wise much better. 93% produced readiness for surgery, and almost even at 50 minutes, you have now about 80% of them having complete sensory motor blockade. Again, you see here that despite your choice here, that even with the ropivacaine or levobupivacaine, we only get about 35 to 40%. This is no different than what you did without subparaneural injection. Now, finally, before I end, I like to show you that this separation of these two nerves into a common peroneal and tibial nerve with spread of drug within the paraneural sheath was something that we were taken aback in the early days when we performed this injection, but it was quite consistent. And you can see there is a septum-like structure that comes up, it gets organized in the middle, and this forms kind of a septum between the two nerves with the two halos that separate the main trunk of the sciatic nerve now, both at and below. As we said, if you review the literature, somebody has already found it before you. The time that often people say there is nobody or no one has done this before, it sometimes means that you haven't looked hard enough. Didier Moret and the group from Montpellier already had demonstrated that if you had separation of the tibial and common peroneal nerve during an ultrasound-guided sciatic nerve block, you often found that they had reported that sensory motor block was complete within 15 minutes, and the separation of the sciatic nerve into two components was often associated with a very rapid chirurgical block. Now, this is a picture they presented many, many years ago. You can see here, now you can see that there's a tibial nerve and the common peroneal nerve, and you can see some hint of a septum here. So what is this? A structure that you see in the middle between these two nerves. Because I'm running out of time, I'm already over, so I just want to quickly mention that it's almost 100 years, more than 100 years from today, that Compton had described the intrinsic anatomy of the large nerves in the Journal of Anatomy. These are his drawings from that very article. You can see here, you can see this is proximal, this is at the mid-thigh. You can see between the tibial and the common peroneal components, you can see he drew a septum between the two nerves. It's where the two nerves come together. And in fact, this is a diagram I drew based on the descriptions of that article. And you can see here, this septum is not going directly anterior-posteriorly. It's an oblique septum that goes through the nerve, sciatic nerve, between the two components. And this is described as the Koku septum. So sometimes when you say somebody's gone Koku, that means no. It's the Compton-Cuvelier septum, based on Compton and his colleague Cuvelier, I suppose. And you can see in this scanning electron microscope, this area is filled with this fibrofatty connective tissue, which Dr. Reyna already mentioned to you. And they come together between the two nerves. Often in histological section, it is more difficult to see in the hematoxylin stained. And when we compared our ultrasound images with some of these histological sections that Dr. Reyna had in his laboratory, where he had injected the red blood cell marker with a hematocrit of about 10, and the injections were performed at the divergence. When you looked at the section above the divergence, you can see that this pink area represents where the red blood cells had spread. And now you can see that it's not truly a circumferential spread. You can see a lot of local anesthetic actually gets into the nerve on either side of what appears to be a composite formation of a septum by these collagen fibers, the blood vessels, and the other structures that are within the architecture of this nerve. And this is just about 11 centimeters above the divergence. You can see between the common peroneal and tibial nerve, there's a lot of this injectate of the marker between the two nerves. And this probably accounts for the septum that we can see in the ultrasound. So in conclusion, I have illustrated to you the subparaneural popliteal sciatic nerve block and how it improves block dynamics. And there are several techniques that have been described, including the twin injections below the divergence. Certainly is not the holy grail of the sciatic nerve block. The two injection below the divergence as a subparaneural injection appears promising. It nevertheless produces very prolonged duration of block with the long-acting local anesthetics. I think a choice of a shorter acting drug may be desirable, and this is an area that we are investigating currently. It produces a high incidence of paresthesia, but fortunately it does not lead to long-term consequences, as our short-term follow-ups have shown. We have drawn attention to the Koku septum, the Compton-Cavalier septum, which was described more than 100 years ago. So now we've come a whole circle after 100 years, and now this is the structure that may play a part in the distribution and spread of the drug within the sciatic nerve. And thereby, if we are to produce surgical anesthesia, we have to pay attention to this septum. Future dedicated research in this area is being planned. Thank you, ladies and gentlemen. With these few words, in fact, many words, I would like to end my talk. So since we now come to the end of this presentation, I would like to welcome the other speakers to join us for this Q&A session. So Christine, you are there. Good. And now, Dr. Reina, are you here?
Yes, I hear. I listen.
Maybe Dr. Reina has other business to take care of. Never mind. Okay, Christine, do you have any questions that our audience would like to know?
Yes, so the first question is for Dr. Feigl. So the question is from Dr. Carlos Correa. So he would like to know whether we can always see the posterior femoral cutaneous nerve in dissections, and also whether this nerve is inside the paraneural sheath as well.
Okay,
that's a question for you, George, because I know you have done some good work in this area.
First of all, no, they are not in the same sheet. They are separated from each other. There is a dense connective tissue layer in between the sciatic nerve, and superficial to it, you have the posterior femoral cutaneous in a fat-filled fascial tunnel. Anyway, concerning dissections, and also there are already enough manuscripts concerning the visibility in ultrasound. The posterior femoral cutaneous nerve is easily detectable and traceable by ultrasound on the thigh region. What is important for you is that you have the posterior femoral cutaneous regularly reaching the proximal third of the leg, and this is not that true because you get a prolongation of the nerve until also the distal leg areas in let's say a third of our cases. What we found was about 30% and 40%.
Thank you, Professor Feigl. So we have another question for Dr. Karmakar. So two questions for Professor Karmakar. So the first question is from Dr. John Tay. So he would like to know, would you try to achieve a circumferential spread with needle adjustment while you are performing the sciatic nerve block? And another question is regarding routinely adding steroid to prolong the block duration, and also use it as a preemptive to prevent preemptive medication to prevent inflammation.
First question, do I deliberately chase the sciatic nerve for a circumferential spread? I think the answer is no. Over my research work, I have now homed in on performing 2 injections subparaneural below the divergence. So as you will see that these are smaller nerves, and I find that it produces quite good spread. Yes, it is not circumferential around the tibial and the common peroneal nerve. But my worry, if you chase and try and create a circumferential spread around the tibial and common peroneal below the divergence, you hazard injury to the nerve. And more importantly, some of the smaller branches like the sural communicating or the peroneal communicating branches, these are very small branches. You may risk producing damage to this. So I don't chase it, but I am more inclined, or if you ask me what kind of a popliteal sciatic nerve block I would want you to do in me, I would say do 2 separate injections into the common peroneus and the tibial nerve below the divergence after hydrodissecting it with some normal saline. Next question is, do I add dexamethasone to my injectate to try and prolong the duration? As I have been saying all this evening or this morning for you or afternoon, that it really produces such long duration that any prolongation is not desirable. I rather want a block that is much shorter, where recovery of the sensory motor function certainly recovers earlier. Now, in terms of reducing any anti-inflammatory effect, I think the jury is out there whether it really works like so. So I don't have any comments on that.
Okay. Thank you, Professor Karmakar. So I think there is another question for any of the panelists. So Dr. Malfetti Antonio Cole would like to know whether any one of the panelists have any experience in evaluating sciatic nerve damage using ultrasound elastosonography.
No, sorry, I passed that. We fortunately don't get sciatic nerve block damage. In my clinical experience of more than 30 years, I haven't seen one, fortunately, put it this way. Fingers crossed, I will end my career hopefully with that. But you have a valid question. Sonoelastography may be one way to look at it, but there are no validated studies to show that if you see changes in elasticity of a nerve, how does it relate to nerve damage or to changes within the nerve? I think if that's what you want to know. So there are no validated measures or studies. So I think nerve studies, nerve conduction studies will still be the gold standard until then.
I might contribute something for that. First of all, when you're at the popliteal fossa level, the nerve is really quite separated already within each nerve. So you have a lot of loose connective tissue and fat tissue in between the nerve fascicles. So you get more space which might be filled up first. Second, concerning the elasticity, we are all getting older. And there is a certain age, which is 40, where you get a huge change of elasticity, which means a loss of elastic fibers, and then a stiffness of the connective tissue caused by a lot of collagen fibers. And this might be a reason that sometimes the nerves do not move that easily as you have a young person, for example.
A very valid point, George. I think for that matter, even skeletal muscles have sarcopenia, if you may, and they have changes with age-related changes are quite common, and they can affect musculoskeletal sonography, if I just put it. But in terms of the question that the doctor put in, there are no validated data as far as I know, and I know that I haven't looked hard enough. But certainly, as far as I know, there are no validated data looking at elastography to quantify nerve damage.
Okay, thank you, Professor Karmakar. So there is another question for you just pop up just now. So Dr. Jamie Pier would like to know, where does the paraneural space end caudally? And do you go paraneural in diabetic patients with neuropathy but with lower dose of LA?
That's a very good question. Where does the paraneural sheath end? I think wherever the nerve ends, the paraneural sheath ends. it is an integral part of the nerve. And I think that is how we should look at it, because when you look at the sciatic nerve, it's a template of a big nerve. But smaller nerves also have this gliding apparatus. It's a part of the machinery of within the nerve. Now we inject deep to it to try and augment our blocks, sensory block, motor block, etc. But when it comes to patients with pre-existing neuropathy or patients with diabetes, etc., I think today there are no data. But based on what we understand about these patients, I think subparaneural injections may not be so desirable in these patients, because then if you do it, then you have to think very carefully as to the dose you use, what drug you use, because you may be left with a patient where you perform a subparaneural injection, and diabetics and neuropathic patients who have neuropathy are known to have very prolonged blocks. So I hope you understand where I'm coming from. So in that case, you have to be a bit more prudent and more judicious in what you do. I think my choice, if you were take a case, say for instance, a diabetic with polyneuropathy who's coming for an amputation, but has multiple comorbidities, and you just don't want to give them a general anesthetic for nephropathy or any other reason, multiple comorbidities, then my choice is give them a spinal if you can. If you are able to overcome this with a spinal, that's good. But when you can't do it in the risk benefit, then maybe a sciatic nerve block with a combined plexus block, either it's lumbar plexus or a femoral nerve block, would be desirable. But you have to bear in mind that these patients will have a very prolonged block. But the saving grace is often that part of the leg is removed. It means they've had an amputation. But imagine a patient who doesn't need an amputation, like a debridement or some much more simpler thing. Then you have to bear in mind that these patients are at the risk of developing very prolonged blocks. And the reason is very simple, is that you are injecting into a relatively avascular area, a large depot of drug, and this washout of this drug is going to be even slower in these patients because of their vasculopathy, and you may get a very prolonged block. So I think that would be the way I would answer your question.
Okay, thank you, Professor Karmakar. Another question for you from Dr. Tony Ng. So is there any difference in the block dynamic for subparaneural popliteal block in the pediatric population?
Tony, that's a good question. Again, we don't do many subparaneural or, deliberately subparaneural in these young patients, because they're often done under general anesthesia. And my principle is, if you are going to do a sciatic nerve block, you're often doing it for analgesia. In this, say somebody having a clubfoot repair, where you do a caudal or you do a peripheral nerve block, then I would usually do a circumferential injection like we used to do in the past. Some of it probably goes subparaneural. But how would it be different? I think that you just bring out a very important question, because I think the washout in these young children may be very fast, and they would be much quicker than, say, somebody who is like you or me. We have a progressively increasing duration and slower offset. So, in younger children, when I do it, I would just do it circumferential injection without really relying too much on identifying the sciatic nerve subparaneural area.
Okay, thank you, Professor Karmakar. I think that's all for now.
Okay, so I think we've had a fantastic evening. We are just about 15 minutes over time. Why not? If the discussion is good, we should keep on going. George, once again, thank you very much, my friend. Hopefully, one of these days I'll fly into Witten, and we should be able to visit your anatomy laboratory and do some fascinating work with what you and me have in mind. Christine, again,
You're
thank
welcome.
you for spending your evening, and I hope you learned as much as I did. And you out there, far and wide, from Venezuela to Algeria to Syria to Colombia to Spain to Portugal, everywhere. This is actually victory of our being trapped inside our homes. We can now communicate. Without this, we would never have been able to bring Professor Boezaart. We would never have been able to bring Professor Reiner, Professor Feigl, and myself together in one same session so easily. And for you to sit in your home with the feet on top of your chair, listening to us in the comfort of your home, this has truly been a wonderful time. So I hope you take away something very fruitful from this session. But as I mentioned, you have to be prudent and apply this information to your patients, being prudent in your own way, in your own circumstance. So without further ado, I'd like to wish you all well, and hopefully we will see you in 2 weeks' time for more fun with the ISSPS webinar. Thank you very much, and take care and stay safe. Bye, George, and bye to everybody.
Thank you, Manoj, and thank you for all.
Sorry, Miguel. I thought you were not here. You are here, so we're going to spend a few more minutes. Thank you, Miguel. You've been a great champion in your own way. Your contribution in the field of microanatomy is truly stupendous. It has left an indelible mark in our field of regional anesthesia. And some folks who are wanting to know what is the textbook of Dr. Reiner, I would suggest you Google Professor Reiner, R-E-I-N-A, in Google, and you will find out in the picture section his textbook. It's a must-have book for anyone interested in regional anesthesia or microanatomy of the nerve. Thank you, Miguel. You are always been a great helper to or a champion and a great associate for the ISSPS. I am totally indebted to you.
Okay, I am in spirit and here with you all.
Thank you. On and on. Take care. Bye-bye, everybody.
Bye-bye.